International in Sweden, Maria Board, Regional Director of LM International, Gloria Mafole. We've been working together since we met last year in my office. The Chairman of the Organizing Committee, Dr. Felix Kums, all members, participants, protocol observed. Guest of honor, on behalf of the Muhimbili University of Health and Earth Sciences, I take this opportunity to welcome you back to your university and participate with us in this important forum, the Digital Health and the Innovation Forum. I'm very humbled to all of you participants, and for those who are online, to be with us, and some of them, they're here in Tanzania, and some of them, they're outside Tanzania. I would just like to mention that the Muhimbili University of Health and Earth Sciences is much more committed to the digital health transformation within the university and in the whole country. I'm informed that this event is attended by interdisciplinary audience of all age groups from different countries in the world. And the main aim of this forum is to rapidly transform the health systems and the provision of different healthcare services. And one of the strategic priorities is in the Tanzanian Digital Health Strategy 2019 and the 2024 is to promote research, innovation, and the development to facilitate evidence-based adoption of the appropriate technologies in the health sector. The Muhimbili University of Health and Earth Sciences, being one of the institutions which has to collaborate with the government of the United Republic of Tanzania and the other stakeholders to achieve this. We know that at Muhimbili University, our students are also involved much in ensuring that digital health and innovation takes place. We have different symposia, debates, and the establishment of the digital health startups from these students. We have been attending different gatherings, and we have seen these students presenting Daktari Mkononi, Dawa Mkononi, Pharmalinks, Afya Tunes, Afya Intelligence, and of recent, the Saratani Artificial Intelligence. We have the honor really to congratulate these students because this university is coming from the long way. When we started in way back 1963, we concentrated most with the training. During the process, we had to include research as the main aim for this university and being the second core function. But we know that consultancies and the services are equally important. Since 3 years back, we have gone to try to go to the first phase university, whereby innovations from the research and the different things which we do has to take place. And the last thing which we have to start now is going to the marketing. Therefore, instead of three core functions of which we are used to have, now innovation and the marketing has to come as the core function of this university. I know there are so many questions from different people on this. Where are we going? Is the university going to the industry, or the industry is coming to the university? But my response is that we have to meet in between and ensuring that whatever we innovate, we take it further for utilization of the Tanzanians and the people beyond the borders of this country. As I said, we have been supporting digital health and innovation initiatives. We have been calling for different stakeholders within the country and from abroad to collaborate with the university to establish the Center of Excellence in digital health, transformation, and the innovation with the aim to accelerate, strengthen, and foster digital health training, research, innovation, ethics, development, and implementation science within the health sector. And today is among numerous events, activities of which we've been undertaking to facilitate digital health transformation in the country. Guests of honor, I would like to reiterate my heartfelt appreciation to you for availing time from your busy schedule to officiate this event. I would like as well to thank all of you who have managed to attend here physically and those who are attending virtually. I would like to applaud the organizing committee, including our colleagues from the LM International. I read LM as Locare Missionale. Locare Missionale. I stayed in Sweden, but my Swedish is very poor. Always I'm trying as much as possible to improve it whenever I have time. But throughout all the documents which I've read, the Tanzanians failed to write it in full name. Therefore, they put it LM International. More than that, Maladalens University, presented here by Sarah. The MUHAS staff, students and members of the MUHAS Digital Health Innovation Research Group, and the service providers for a job well done. I also want to thank the speakers, panelists, as well as collaborators from abroad. I would like to acknowledge and appreciate the huge financial and the technical support from different partners and sponsors for this event. Most, they have supported us in different ways, and really, we appreciate, and we shall continue in this collaboration in order to advance digital health in Tanzania. Yes, of honor. I was not here to give a speech, but just to introduce what MUHAS is doing in order to advance what we are doing. The only last thing which you have to point out, we have the collaboration between MUHAS, LL International, the Maladans University, and currently we are trying to put a collaboration between MUHAS and the national government of Zanzibar so that we can support them to advance digital health in Zanzibar. We are drafting the memorandum of understanding, although we have been collaborating, that's the truth which I can say, since 2 years back, been working together. Felix has been going there several times, trying to advance this, but we want to formalize it and having the memorandum of understanding between MOHAS and the Lieutenant Government of Zanzibar. And when it's ready, we are going to sign it. What we want to say, we shall continue to collaborate with the government, especially the Minister of Health, all partners and the stakeholders, and organize similar events in the future. MOHAS will strive to be the next generation university. And now humbly, guest of honor, Dr. Pius, welcome you to officiate this important event. Karibu sana, Jamhuri ya Muungano wa Tanzania. Thank you. They will give the notes up there. Please. They will give the notes.
Vice Chancellor, Muhimbili University of Health and Allied Sciences, my friend Professor Andrea Pembe, Professor Apollinari Kamuhabwa, Deputy Vice Chancellor, thank you. Vice Chancellor, Muhimbili University of Health and Allied Sciences, Professor Andrea Pembe, Professor Apollinari Kamuhabwa, Deputy Vice Chancellor, Academic Research and Consultancy, MOHAS, Dr. Roderick Kisenge, Acting Deputy Vice Chancellor, Planning, Finance and Administration, Professor Sarah Wamala Anderson, representative of the Mälardalens University in Sweden, Gösta Markelsson, Director of Innovation and Digitalization at Locale Missionale International, Sweden, Maria Bott, Regional Director at Locale Missionale International, Gloria Mafole, Country Director at the same Locale Missionale International, Tanzania, Engineer Samson Mwela, Director of Knowledge Management, representing the Director General of COSTECH, Mr. Silvanus Ilomo, Director of Information and Communication Technology, the Ministry of Health, Mr. Eric Kitali, Director of Information and Communication Technology, the President's Office, Regional Administration, the Local Government, MOHAS Deans and Directors present, Mr. Mohammed Habib, Head of Information and Communication Technology from Ministry of Health Zanzibar, Dr. Pascal Mdoe, Managing the Medical Director, Haydom Lutheran Hospital, Ms. Nema Ringo, representative of the Norwegian Church Aid, Michael Calopietro, representative of the World Diabetes Foundation from Denmark, chairpersons and members of the organizing committee of the MOHAS Annual Digital Health Week and the second Tanzania Digital Health and Innovation Forum 2022, representatives of various government ministries, departments, and agencies, representatives of various development and implementing partners, Dr. Felix Sukums, Chairman of the Organizing Committee, representatives from local and international CSOs here present today, MUHAS staff and students, members of the press, distinguished guests or participants present here, and those attending virtually, invited guests, ladies and gentlemen, and again, Joost Markerson, welcome in Tanzania. And all protocols observed. Ladies and gentlemen, a very good morning. I decided to go back to Joost because I was in Norway in 2006, and I had a Swedish friend, Ingmar Framberg, whom I used to visit in Lidköping. I used to take buses to Uddevalla. So I still remember some Swedish. He was a good friend of mine. I would like to use this opportunity to welcome, first of all of you to this important meeting. To anyone here who has traveled to Tanzania from other countries or from other regions to Dar es Salaam, and to you joining the online and attending this meeting virtually, it gives me a singular pleasure indeed to say Karibuni sana Tanzania. And the Karibuni sana means you are warmly welcome, particularly to this beautiful city of Dar es Salaam, which in Arabic it means abode of peace, Tanzania. It is indeed wonderful to see so many people from within and outside Tanzania who are committed to a digital health future for transforming the health system in Tanzania. Distinguished guests and participants, I feel honored and grateful for the invitation and opportunity to spend the next 2 days with you at this year's Digital Health and Innovation Forum and Exhibition. My standing here is due to being sent by the Minister for Health, Honorable Umi Ali Mwalimu, who asked me to bring you 2 solid messages that I'm going to mention them at the end of this speech. I am also conveying greetings by the Deputy Minister, Dr. Gordon Mollel, the Permanent Secretary, Professor Abel Makubi, who nostalgically remembers this place that nurtured him and became a professor and then became the Permanent Secretary. His heart remains here. Equally, I have brought to you very warm greetings by the Tanzania Chief Medical Officer, Professor Tumaini Joseph Nagu, who has recently become the government Chief Medical Officer and wishes to greet you nostalgically. After having conveyed the greetings and the 2 messages at the end of this speech, I wish to tell you that I'm glad that the Ministry of Health is collaborating with Muhimbili University and Allied Sciences, MUHAS, the President's Office, Regional Administration, Local Government, Pure Large, Locale Missionale International, Malodens University, MDU of Sweden, and other partners who have collaborated in organizing this international level forum. We wish to express our sincere gratitude to these international collaborators and we want to assure them of the continued government support in recognizing their contribution towards this endeavor, where we aim at reaching every citizen of this country, irrespective of where he is, because technology, unlike physical barriers of cars and others, technology is able to reach people wherever they are, so long as they remain connected. Distinguished guests and the participants, digital technologies are immensely and rapidly transforming numerous aspects of lives, including health systems and other provision of health care services. The Tanzania Digital Health Strategy 2019-2024, in line with the WHO Global Strategy on Digital Health 2020 to 2025, prioritizes implementing digital health interventions to address challenges in the health sector and to strengthen health systems. Furthermore, the strategy aims to accelerate the transformation of the Tanzanian health system through innovative, data-driven, client-centered, efficient, effective, and integrated digital health solutions. Indeed, as I was approaching these premises, the chairman of organizing committee, doctor, and a friend of mine, Felix Sukums, hinted that just 3 days ago, there was a course here on data analytics, aiming at empowering people to understand and interpret the data. Because when you have improved technology, you acquire more data. The question that follows is making sense of the data. Empowerment in analytics of the data, so that important messages are obtained from the data for action is key to improving lives, because that's where you're going to know where to intervene. Because without data, you cannot know where the problem is, the magnitude, and therefore the planned intervention. So I want to congratulate you, Dr. Sokums, for this noble work you're doing. The Vice Chancellor has already done that, but I wish in my capacity to congratulate you on this initiative and hope you take on a strong heart and take it to the next level. Likewise, the digital health strategy, among other initiatives, promotes research, innovation, and development in digital health technologies to improve the delivery of health services for better population health. This emphasizes the importance of fostering research, innovations, and development to facilitate evidence-based adoption of appropriate technologies in the health sector. In line with this, universities and the health institutions are urged to collaborate with the government to implement the above-mentioned strategies. A few minutes ago, the Vice Chancellor affirmed that between innovation, technology, and marketing, which one should come first? He has confirmed that academia and the industry must meet in the middle. I was carefully and attentively listening to him because, in my view, universities host academia. Industry is business, is hardcore business. When I was in Norway, I could see the meaning of industry. A lot of research is done in the industries. You have a department of research and development in many big companies. ironically, many companies have turned to universities when they want to do research that informs their operations, what we call operational research. I wish to agree with the Vice Chancellor that blending the two could result into a better product, because you have think tanks in universities, but at sometimes universities lack funding, especially when in these days, some dons do not put up many grant applications. So they turn to industry for funding. So Vice Chancellor, I wish to agree with you that we must meet somewhere in the middle, because you have the brain in universities and the industry has the financial muscle, but you cannot do research without funding. So somehow, somewhere, we should complement one another. So coming together in a meaningful collaboration is extremely important. And that means if we want to take these technologies further, the think tanks in universities need to collaborate with industry or partners. And I'm happy to see our northern partners, because they are coming to put hands together so that we make sense in transforming health towards universal coverage. There are two areas that the Minister for Health emphasizes, Honorable Umi Ali Mwalimu, that one, we should aim at quality healthcare. Secondly, we should be able to improve the information. In the ministry, we have a challenge of enhancing and making the health information system robust, few, but making them able to capture important data. So if I see this event today, it gives me hope that some of the questions that we have locally are getting to be addressed. And I should commend the Muhimbili University for taking this lead. So I wish to have a little few seconds applaud to Muhimbili University for really taking up this task. Distinguished guests and participants, at this juncture, I want to applaud again MUHAS for taking the lead and creating this outstanding platform to connect key actors in the health sector. MUHAS has been facilitating platforms for scientific conferences and engagement, dissemination of research findings and policy briefs, and other capacity building initiatives in the health sector. Additionally, in the digital health space, MUHAS has been at the forefront of supporting the ministry and the other stakeholders in various digital health related interventions. Their excellence in teaching, research, consultancy, and public services is clearly unmatched. The recent ranking has vividly demonstrated this by Times Higher Education World University Rankings 2023, which ranked MUHAS as the #1 position in Eastern Central Africa. #5, I wish to hear a clap on #1 position in Eastern Central Africa. Being #1 is really something remarkable, and I wish to maintain this position, because maintaining a position takes more muscle than attaining a position. So, Vice Chancellor, on behalf of the Minister of Health, I wish to congratulate you for clicking this position. Number 5 on the African continent. And among the top 500 universities in the world. Distinguished guests and participants, today's forum is the first of its kind because it involves a number of government institutions responsible for health and the social welfare, as well as information communication technology, e-government, etc. There are also presenters from different partners globally, from Sweden, from United States, from UK, Denmark, Kenya, Nigeria, Ghana, and Ethiopia. More so, sessions of the forum cover policy and the governance aspects, implementation of digitalization, as well as prospects and opportunities for the use of emerging technologies. This is one of the efforts to support the implementation of digital health initiatives prioritized in the digital health strategies. The aim of this forum is to share experiences and expertise on how to appropriately adopt and use digital technologies to transform and strengthen our health systems. Specifically, the forum will explore strategies to foster digital health research and innovations and promote the adoption of affordable and appropriate innovative digital health solutions and services in addressing health systems challenges. Please bold and underline affordable and appropriate, because I'll come to that shortly. This initiative will contribute to the implementation and improvement of the digital health strategy and other related strategies in the health sector. We are very excited about the forum, and I hope you find the various presentations and the discussions, which will cover several themes, including strengthening leadership and governance for digitally transforming the health sector and implementing the digital health interventions for better health outcomes worldwide. Ladies and gentlemen, remember that in the 6 WHO pillars, the first pillar is leadership and the governance, because leadership is key. In the 13th priority areas for this year in the Ministry of Health, innovations in digital health and the strengthening digital health is one of the priorities, to be exact, the 13th. And we are committed to making sure people who take initiatives like MUHAS will enjoy the patronage and the support of the Minister of Health. This is the first message I referred to when I started this speech, that I will deliver. And this was singularly, clearly articulated by the Minister of Health, that I should say that the ministry is going to support initiatives by MUHAS and give all the support it requires. The second message is coming soon, in a few seconds before I finish this speech. Distinguished guests and participants, the theme of this forum is attaining universal health coverage through digital transformation. This aligns well with the efforts of the Tanzanian 6th government leadership under the leadership of Her Excellency Mama Samia Suluhu Hassan, the President of the United Republic of Tanzania, which is working towards the universal health coverage. The government has tabled a bill in the parliament to act by universal health insurance for all Tanzanians so that they can access the health services they need when and where they need them without financial hardship. The ministry fully supports these initiatives and a cause for different stakeholders within the country and abroad, in this case, our partners who are present here today, to collaborate with the university in order to achieve these long-term goals. We call on all stakeholders to maximize collaboration and partnerships using the quadruple helix model of innovation as a unique platform for the government, industry, university, and technology participants, many of whom are represented here today. Collectively, they are already proving to be a true power for good in delivering cutting-edge digital health research, innovations, and applications. Moreover, as I have reiterated several times, the need to ensure high-quality data and promote data use in the health sector. I urge you to use this platform to deliberate on strategies for improving the implementation of appropriate and interoperable digital health solutions across the health sector for improved resource management and overall health system performance. So the second message the Minister, Honorable Umi Mwalimu, asked me to deliver is, as you deliberate on various aspects of innovations in digital health, please come up with how the various forms of systems in different health facilities could be interoperable, so that if different health facilities have different platforms, how do these platforms come to read each other, so that at the end of the day, the end user of the data, who is the ministry, can come up with uniform variables that can be analyzed and interventions decided upon, informed by data. So this is the second message I was asked to deliver. Deliberate on how to make the systems, the technologies interoperable. I'm a clinician, but I understand there are certain aspects of health information mediator that could be thought of. You are the experts who would come up with the best way to do that. It is not forgotten on our minds that there are costs involved. However, affordability should also be considered. So before I take my seat, ladies and gentlemen, I would like to acknowledge again MUHAS for the continuous collaboration with various government ministries. I'm sure the Vice Chancellor understands why the ministry acknowledges this, because Professor Andrea Pembe has been in the forefront very positively and engagedly working together with the ministry to make sure that we have the best human resource for health possible, disciplined, trained, skilled, but also supporting the ministry in making sure systems work. So we thank you very much, Professor Andrea Pembe, for your help. We also acknowledge departments, the government departments and agencies, as well as development partners and implementing partners to foster digital health and innovation on implementation and evaluation of digital health initiative in Tanzania mainland and Zanzibar. I wish to reiterate this area that our development partners need a special applause. They need a special applause because through them, not only have we obtained some concepts, but also we have enjoyed their patronage in logistical and the means of accomplishing some aspects of software we are. I don't remember if Dr. Felix Sokons was with me, but I remember Hassanali Msangi. I do not know if he is in this room this morning. Hassanali Msangi was coming from the then starting rudimentary ICT department in MUHAS in 2005, where I went with him to University of Bergen in Norway, specifically Haukeland University Hospital. Dr. Felix, you remember, I expected him to be in this room because he would be my witness that through development partners, we have gone this way. And that's why I asked the audience to join me in applauding them. MUHAS has led a digital health landscape assessment and development of digital health strategies for Tanzania and Zanzibar. Similarly, MUHAS has produced an artificial intelligence-based solution for the early detection of tuberculosis, which has resulted in a reduction of time and the costs for TB diagnosis and treatment. And this is very significant because late TB diagnosis leads to many complications, most of them very fatal. The university has other ongoing research and innovation that will further benefit the health sector at large. I would like to lastly reiterate my heartfelt appreciation to all of you, both present physically and virtually, who have managed to attend this event. Congratulations to the organizing committee led by Dr. Felix Sokons for a job well done. And finally, I would like to thank the presenters, panelists, and exhibitors, as well as all collaborators from abroad. I wish you all active participation and engagement throughout the 2 days. We look forward to receiving deliberations on improving the implementation of digital health initiatives and data use for better population health outcomes. Also, we look forward to seeing similar events in the future. I know this is the second forum, but a third is, I believe, being planned immediate after this. I call upon the Ministry of Health units. I saw Sostenes Bagume entering, who is in the Ministry of Health in this very endeavor. Departments, programs, and agencies to work closely with the higher learning and the research institutions to conduct thorough assessments and enhancements of data systems and the data use across the health sector. I believe inspiration from this event will lead to new ventures, because innovation is a never-ending event. So, distinguished guests and participants, I now have the pleasure of declaring this two-day hybrid digital health and innovation forum and exhibition 2022 officially open. Thank you very much. Asanteni sana. Jamhuri ya Muungano wa Tanzania. Na naomba kazi endelee kweli, kwa sababu tunahitaji sana platform hizi ili kuweza kufikia watu wengi, hasa tunapokwenda kwenye bima ya afya kwa wote, ili tuweze kufanikiwa vizuri. Na natumaini bunge baada ya kusoma mswada mara pili, Mheshimiwa Rais atasaini kama sheria. Nashukuru sana.
Asante sana mgeni rasmi. Naomba I know that is not a protocol. I've been told that if I guess the Hannah is spoken, then nobody else should speak. But this is innovation. Doing things in the better way to do it. Guests of honor, foremost, I thank you so much for the speak. We have noted the importance of us leading quality of care within Tanzania. But secondly, on the support which Ministry of Health has guaranteed us, but has promised to continue providing to MUHAS. And thirdly, on the whole issue related to interface of different platforms which are used to collect data in Tanzania. I'm sure that with this forum, something on this will be done on the interface and have much more discussion. We have about 67 programs for data collection, at the same time managing the hospitals in Tanzania, and sometimes they don't read to each other, not only across themselves, but also across other programs in the government. And that's been always a challenge when you're visiting these facilities. Thank you so much. Because of innovation, and as I said, those are my remarks. One, thank you so much. My second remark will come from Mr. Makason from ML International. 2 minutes, please, as part of the vote of thanks. There will be no political, the politics, say the protocol there, everybody's upset. Very difficult to pass them. Okay. Please.
Thank you very much. I would just like to start with saying that breaking the protocol is innovation. I'm very happy. Anyway, we are very grateful to be here. We are 4, 5, 6 people from LM International, Locale Internazionale, as we now call. And we would like to thank everybody who's here to come to this meeting, the distinguished guests on the panel table, and especially my new friend, that we are so honored to be in the same room. And we hope that we'll create all together the best, and the most innovative forum ever. And then we think about already now, if we are so good here together in cross-fertilizing and come from different parts of society, what then would be the third seminar? And I feel myself already inspired. And as soon as I know when that is, I will order the book. Thank you very much.
The third remark will come from Professor Sarah Wamara. Professor Sarah, please.
Thank you very much. I'm extremely pleased to be here, and my special thanks to all the speakers from the ministry, from the MUHAS, from LMI, and all others who are here, and participants. It's very important, of course, that you are here, and even those who are online. And this is the beauty of digitalization, that we can do both. We can have people on board who cannot be here physically. I think that's a great opportunity. Having grown up in a very close country in Uganda, being here in Tanzania, it feels really great in my heart. I usually say some things make me feel like I have this big sun shining in my heart. All these days I've been here in Tanzania, that's what I have felt, that the sun is not only out there, it's been in my heart. And I'm extremely pleased for MUHAS, for that Vice Chancellor, Professor Pembe, and my friend, Dr. Skumos. I think it takes the courage to be the first to do these kinds of things. And the support from the leadership is very important. And that's what we see in MOHAS. And for us from Maryland University, I have to tell you that I'm rather new. I started in 2020. And when I came to that university, I would say I'm the only Black person who is on staff. We have many students of color, different colors in studying at, bachelor's, master's, PhD. But in the staff, we don't have representation. And I happen to be the only professor in health and welfare technology in the whole of Sweden. I think there is a similar professorship in Denmark. But what I realized is that even if Sweden is a rich country, we cannot do things ourselves any longer. We have to collaborate. And now our universities in Sweden have understood that internationalization is very important, but many of them are still struggling, like my university, to see what we do about internationalization. For us, signing a memorandum of understanding between MOHAS and LMI was an important step towards internationalization of studies and research in Sweden, and especially at my university. I was at Karolinska Institute before as a professor of health policy. It was different. It's a bigger university. We had many international students, and internationalization was, the order of the day. And I think the digital transformation is also helping to see that we have to act beyond the borders. And I have to say that I have a lot of support from my university. My dean would have been here, but was already occupied with other things. As we say here, let this be a place to be at MOHAS, or whether it's any other place in Tanzania or our new friends in Zanzibar. Every November, we know that we are talking about a digital transformation. And me, I'm looking forward to that. So I think I'll be reserving that week. I'm waiting for my friend, Dr. Skubos, to know the dates. I'll reserve that. Nothing else is going to stop that. I believe in collaboration. And from my part, I think the platform I have, what I can give back to the continent, which gave me so much, which built up my resilience, and to my friends in Tanzania, you are great people. Yeah, it's just amazing the people I have met. It doesn't matter whether you meet them in a market or whether you meet them anywhere else. The warmth you have in the heart, it just strikes everybody. There is something special with Tanzania. I think I know many countries, and I've been there in Africa, but Tanzania is special in my heart. And I'm really pleased to be here. I'll be happy to support many students as possible. We have possibilities of offering a master's program. And of course, there are some scholarships through Swedish Institute. They are competitive, but it's not impossible. We have opportunities to provide PhD positions. So I'll be happy to support that. And then another one is around publications. Yeah, because there is so much going on here, but it's not published. And we're talking to our friend Mohammed, the great work he's doing in Zanzibar, that this has to get out and people get to know the great work you are doing here. So we are looking forward to collaborating with you and also setting up research projects because it's possible. And I'll tell you another secret, by the way. Don't tell anyone. Africa is on the top of the agenda now. So many universities, I met with a couple of universities a few weeks ago. So they are setting up, in terms of organization, to have an African strategy. So many people want to work with Africa. So you're already on the top of things here. So there are so many reasons for that, because this is the youngest continent. I'll tell you that in just a couple of years, Europe will be the oldest continent. So young people is a great capital. So education and innovation is really very important. So international collaborations is a must, and that's the only way we can go. Thank you so much.
Sarah. Thank you so much, Wilson. In Africa, there is one saying.
If you want to go fast, go. If you want to go far, with others. Go with others, therefore collaborate. Thank you so much, guest of honor. I'm sure this is time to have a photo. We'll start with the first group will be collaborators, and then all photos will move. We shall do it outside there. I'm short of time, that's why I'm running.
Thank you, Vice Chancellor. Just another hand of applause for all the speakers that have spoken today. Thank you. So we can go outside. We'll have the first photo with our collaborator together with the organizing committee. When I speak about collaborators, all our supporters and LM International, Maladam University, UWF, TDA, Ministry of Health team from here in Zanzibar, Porlag team, Farmers Access, Farmer Access, COSTEC, Norwegian Church Aid, IDOM, all the partners, please, can we go outside a little bit faster because our Vice Chancellor is late a little bit, so we can take this photo together with the organizing committee. This is going to be fast. We will network. After that, we can go direct to the tea break.
Unafoda India.
People.
Really amazing.
Hello, good morning once again. Unfortunately, the team were really late, so on behalf of this. We will come to meet right after the rest. I have it. That one.
This one.
Yes. How are we going to share so they see?
Yeah, I will show.
Just set it outside. No, it should not be. Okay, I'll just do it. Thank you very much. This is I want to take. Oh, yes. We start now?
Somebody else say, oh, what's it? Not even looking stuff. Just give it a second. So we can. Okay. The region is now the study the start presentation. This would be our work and know that we give our kind of applause needed to be before it begins. To give our more confidence.
Thank you very much. Thank you for being here, and for all of you online, you are welcome here. I'm putting up this PowerPoint to connect here, so you can, shut down everything else you are thinking about that is out there. I would think about so many different things, what I'm planning to do the next hour or so. So let's do that, and we cut that off and reconnect here to be here. So I would like to suggest that we take a deep breath 3 times and just, be here in this room. And for all of you online, be here in this digital room, okay? 3 times from the stomach. Thank you. Now we are here. And I'm really pleased to share this moment with you. I thought that I would talk about different things like trend overview. I'll be broader, high level things. I'll be talking about what is going on. And I'll talk about some opportunities, how digital transformation can transform, strengthening health systems in Africa. New research agenda that could be needed. I think this is important for universities to rethink research. How do we do new research to relate to digital transformation? And I think this came very clear from the Vice Chancellor at MUHAS, but also from the Minister of Health. Then I will end with reflections. First of all, I would like to thank everyone who have been involved in this process. As you saw outside there, we have those collaborators who have made it possible for this conference. But I would like to highlight, especially Dr. Skumos, who has been, connecting everything, all the dots to make this happen. It's very difficult to organize a conference. I've organized many of those conferences, but there are so many details you don't see when you are at a conference, and they take a lot of time and a lot of energy. So I would like to thank you all, the organizing committee, who have been doing this great work. I can imagine how much work you have put in, and congratulations for that. From Maryland Dolan University, so we have 4 schools. It's actually a multidisciplinary university. It will be like faculties. You will have one with the health and social care, that's my faculty. So that will be everything around health and social care. And then we'll have one innovation and digitalization, and then we'll have another one with education, and another one with economics. So this is the research group which I started when I started at Maryland Dolan University to build up research. That was my task. So the things we look at is actually the implementation of technologies. So after innovations, what happens? So we look at go-to-market strategies, what evidence is needed, and then when it comes to implementation, which is complicated, and I'll talk about that. So we focus on things related to policies, reimbursement, who pays and how, when they are going to pay, evidence and value from different perspectives. And I think it came out very well here in the morning. When it comes to technologies, there are so many other end users, could be the health professionals within the health systems, but could be also the government, the policymakers, but also the citizen or patients, right? And the technology developers also want to see which value they get. Then we talk about economic gain. So we have different kinds of end users when it comes to technology, which makes it difficult. And we move into implementation. How do you start to do the implementation? I'll talk a little bit about that. And effectiveness, then we are moving, if you know about clinical trials or any studies in interventions, you are moving from efficacy to works for a few persons who have been in the study, but then you want to know how does it work in a larger population in the real world. I would like to encourage you, we have research webinars with these series, and they are very interesting, they are very well visited. They come every first Thursday in a month, between 3 and 4, that's the Swedish time. Now in Tanzania will be at 5 to 6. So feel free to just, log in. Usually it's on our website, and I have these links here. You can get them. Trend overview. I see that I have another presentation. I'll just go through other things. But here, what we do see that we've been talking about telecare. It has been a development of over many years. We've been talking about telecare, telehealth, wearables, applications, electricity monitoring, remote medication. So when we are talking about digital health technologies, they involve many other different aspects, everything from telehealth care to M-Health. But then we go into also software platforms like, health analytics, digitalization, digitalized health systems. So usually when people talk about digital health technologies, I want to see what is it, what function is it targeting? And when it comes to monitoring, it's important to know which indications, which diseases are you looking at, because we have a tendency to generalize these things. And of course, it will work differently depending on which technology exactly are you looking at. Is it a software platform for decision-making and planning of healthcare and patient pathways, or is it a medical device that can be used for monitoring, for diagnostics, and then you get into artificial intelligence and all those things. So it's important to understand which digital health technology are we looking at. And then sometimes it comes into interoperability problems, because if it is a platform, thank you. If it is a platform, then maybe you need to link it with other digital solutions. And when it comes to evaluating the effect, then it becomes complicated. Why? Because you don't know which part, which dimension of that digital platform that is actually adding value. So it becomes really very difficult. And when it comes to paying, are you paying for the whole system? And what happens, maybe you have different developers and different suppliers, and how are you going to deal with that? I like this picture. This is the digital health market sites. There are a lot of analysis being done on digital health to see what is going on. And this is fascinating because the market is going to grow by 2028 to 430 billion USD. And the growth is 17%. There is no country today that has economic growth at that level, but digital health technologies do have. Can you imagine? And most of the technologies, actually, those are the ones which are used outside the clinical environment. So those, go back to telehealth care, maybe it's about communicating with your doctor or nurse, or is it about monitoring Or is it about alarms setting systems to know that maybe your blood glucose is high, you have to do something. So most of these technologies are around there, and this is where the biggest market is. But who are the giants who are producing these technologies? You are going to learn some Swedish. Milliarder, it means billions, right? It means billions. So these are the big gamma technology giants. That's why many people ask me, why don't you have a digital watch at smartwatch? Yeah. So who produces those ones? So we have one with Samsung, but we have also another one with Apple. Apple now have the 7. They wanted to go into monitoring blood glucose. They didn't get it through FDA. And there are other many ethical aspects related to that. They did a very interesting study, the biggest so far, clinical study. It was about 480,000 participants in it. They wanted to see how can this smart watch predict atrial fibrillation, because it will be showing how your heart rate goes down and up. And of course, you can predict it. Because you are wearing this watch, then you'll be able to have it over time, which is a good thing. But they could see that they could predict about 3% of atrial fibrillation, which people didn't know about, which is a good thing because it's about early diagnosis and early detection. And once you do that, then you get into early treatment, right? That's where you save lives and also save money. But if you look at this, Amazon, Apple has 20, this is the richest company, 25,800 billions. These are dollars, right? And then the next one, we go to Microsoft. Microsoft is very aggressive now when it comes to health analytics, especially the dashboards and all those things. And what they did recently, actually, for about 1 year ago, all of these big giant companies. Can I have a hand for all those who are physicians in this room? Can you raise your hand? Physicians, medical doctors. You are one. I'm a dentist. Okay. I met a few. Oh, raise your hand higher, but not even see it, Annabelle. So doctors now, you are going to be employed by these big tech companies. One of my friends who's been a medical doctor and PhD in Sweden was recruited by Microsoft as VP for their health director. They have never done that. And why are they doing that? Companies are very smart, yeah, because they are getting into the medical area. They want to win their credibility. They must have doctors on board. So when you are trained as a doctor now, don't think I'm going to work in a hospital, right? Because maybe you'll be working with them with a tech company. It's very interesting. And of course, when you put a medical doctor there, it feels really good. Then you know how you can use those technologies to really get the best value when it comes to healthcare. Google, we work with them in other projects. It's called the nudging project. So Google, when you go into the Google, they have different applications. One of them is to encourage you if lifestyle related. If you don't want to go do physical exercise, then you'll be nudged with alerts how to do that. Very interesting. They're also moving into the, you remember that graph I showed you, different solutions within the digital health. Amazon, they also have plans. Meta, this is the first one. Then I was trying to compare. Sweden is a rich country. I wanted to understand how rich Sweden is. So I pulled out the data compared to the tech companies. You see, $5,000 billion. What do these things tell us? Who is going to lead the digital health technologies? And where do we need collaborations? I think it was your chancellor who was talking about working with the industry. Is it the industry coming to the university or university going to the industry? there is no choice. It's going to be collaboration. I'll tell you later why, because they need to research and to produce the evidence of digital health technologies. So this is something to think about. Who is going to own the data? There is a big discussion about iCloud data, which ends up somewhere in Seattle with one of these companies or somewhere else in the US. How is that data being used? Data is one of the biggest commodity right now to do business with. This comes from the WHO, and I like it when I talk to my colleagues who are engineers, who are innovating new technologies. Most of the time when you are doing, there is a process. It's like we have worked in the pharmaceutical industry. It's interesting when you look at their drug pipeline. It goes through different phases. And that's what also technology is needed to do, to go through different stages. Pre-prototype, you want to understand what's the problem you want to solve with the technology, and then come up with a prototype. I'll talk a little bit more later about that. And then piloting to see how it works. And most of that time is 1 or 2 patients that are being piloted. The problem is most of the technologies, they end there, because the engineers, they don't know how to handle this part, the demonstration and the scaling up, and how it gets integrated and sustained within different programs. And of course, why is it difficult? Because you get into the rich multidisciplinary science, but also multidisciplinary professional roles that you need to have on board. So you are talking about organization aspects, reimbursement models, policies. We're talking about multiple users, as we talked about, various technology components, ethical and legal aspects. And of course, when it comes to legal aspects, that's a big issue right now. And the usability, it's about preferences for those who use the technology. And how are you going to measure and demonstrate value and effectiveness? It gets really tough. So this model is being used in research. It came from actually engineers at Stanford, because first, engineers say, I have an idea. I think I can develop this technology. I mean, they can do it. They can find very different kinds of solutions from the idea they have. And now they discovered that you can't do that without involving who is going to use these technologies. And maybe I need to know more about their preferences and their needs. So that's why you have to use this design thinking that you start with emphasizing. That means that you need to understand what their needs are and the preferences, define them, analyze them, and then start to do the ideation, prototype, and test it. And as I said before, most of the technologies end there. They don't go into the implementation, and they are not evaluated to being able to do the scaling up. And also reevaluate again to see if the preferences and needs were really reached. And what this does, of course, with a design thinking model is that it has a human-centered design process and usability perspective. I mean, it doesn't make sense to have a technology which you say, oh, this looks really awesome. I'm just looking at it. I don't care whether it is being used or not, right? So that's why, the technology, the human interaction now is very high on the agenda. And of course, there are different kinds of technologies for cats and dogs, and those would be the users. Then you need also to think from their perspective. And when it comes to technology that are platforms that are being used within a healthcare setting, you need to involve the healthcare professionals who are working in those areas. What happens most of the time, I meet so many engineers, then I ask, did you involve the people who are going to work with this technology? And then they think about this, and they didn't think about it at all. And that's why when they start to test the technology, they find out so many things that do not work. And sometimes there are risks also involved. And within the pharmaceutical industry, we call them side effects, but the risks of technology can be really, really bad because they cost a lot of money, first of all, and then it becomes a lot of waste of resources. This is interesting because we're talking about, I think I was talking with Dr. Skumos. Oh, we have problems with the reimbursement. We don't have any model for that. We don't have a framework, but we are not alone. The whole of Europe is very advanced. We have advanced health systems, right? Who pays for what? We have price tags for each diagnosis, for each treatment and everything. But we still don't have in many countries a framework how we are going to implement digital health technologies. This is a report which was done by Lovell, very interesting. I have a link here. So many actually countries, they are still laggards. They don't have any framework at all, and they don't have plans. And others, they are on certification part. One of them is England. We've been working a lot with them. They have a model which is best. It's called the NICE evaluation model, which helps companies to know which evidence is going to be needed. And I'll tell you a little bit more why these frameworks are needed, especially in Europe. And many other countries, they are called fast followers. They don't have any framework. They don't have any kind of evaluation certification process. And one of them is Sweden. And we've been writing a lot of debate articles around that we are wasting money because we don't have any framework. And I'll show you a little bit some of the research we did to show what really happened. And then others, which we call leaders. The leaders who have the certification process. When you have a technology, you know where to go before you are going to sell to the health systems, and you know exactly how much you are going to be paid and which evidence they are demanding. All that is paperwork showing the evidence, and how the cost contracts about procurement and reimbursement are going to look like. There are only 3 countries. And I was talking in German. I congratulated them last week. They had also an European Digital Health Day. Everybody was surprised because many people don't know that it's only 3 countries. Germany, they've created a new organization. It's called DIGA. So companies know exactly, and decision makers know also what to demand. Another country which is following came later is Belgium. And now France is going to repeat the DIGA's model to do the same thing. I have to tell you that the healthcare, and that's the differences. When we talk about digital health technologies, we are going to market and we're going to implement. We need to think about how health systems are organized, are funded, financed, and managed, because healthcare systems in Europe, they are funded by taxation revenues, which is not the same thing in many of the countries on the continent. It's a mixed model, private, get out of the pocket, and the government maybe payments unclear what they pay for. So still we have problems in some challenges in Europe, but you on the right track that you are starting to think about the procurement, the reimbursement models, who is going to pay for what and when and for how long. So this is a paper we did. So it's a big database for the public, because we have a public health system, right? And of course we have mixed model, we have private ones also. But the thing is, so all the public procurements, we have a big database, it's all about transparency and openness. So we could access this database to see all the companies and technologies that received the procurement and what happened. And it was worth actually 3 billion kronas just a few years, during that time. But what happened, what we saw is that only 1 out of 10 demanded for some kind of evidence and some kind of certification. So in Europe, we have a legislation, and of course, the legislation you need to go into to understand which regulation are we using. In Europe, there is medical device regulation, which means you have to provide the evidence before you go to any market or European country. And after you are in the market, after implementation, you have to continue to show the real-world evidence. So when you think about models also here, you need to think about how are we going to know that it really works and it gives value. I will not go through that. I'll talk about this. I was fascinated when we were together with LMI, Dr. Skumus organized this. Muhammad is here. Yeah. So, so it's interesting really to see that you have, I know that there is one for Tanzania and there is one for Zanzibar. That's fascinating, a great start to have a national digital health strategy. And of course, this is a process. You start there and then move forward. It's a very good thing. And also starting to think about smart hospitals. This is fantastic. And what I find, as I say, the capital that the whole African continent has is young people. I mean, 75% and up to 30 years. Can you imagine? Seeing all these young engineers involved in designing the smart hospitals. We got to understand that Zanzibar is planning to roll out 11 public smart hospitals where digital health technologies will be the central part. We need a new research agenda to provide relevant answers. You know, research is about asking questions. For instance, how does it work for the end user? How does it work within the system? And then you get answers. And as you saw, we need actually multidisciplinary teams involving different kinds of disciplines. Otherwise, it's difficult to get the answers. This is again the WHO report. I would really recommend you look at it. It's really very good. It's called Monitoring and Evaluating Digital Health Interventions. It's very technical. It gives you ideas. How are you going to do these interventions, right? And what you see from this report, actually, from a usability perspective, only 20% is about technology per se. The rest is about usability, the implementation, research, feasibility, economic, financial model, the things we talked about, organizational aspects. So I usually talk with engineers that when you have your technology, you are only solving 20% of the problem. So the rest has to be solved in a different way. I cannot emphasize enough, that's why we like collaborations from our university, that we need ecosystem perspective. Well, in order to have an ecosystem perspective, we have to move away from this collaboration model we have been having, only academia, public sector, business sector, but broader to involve citizens, innovators, and citizens. Of course, you are talking about other representatives of citizens. That's why we like to work with LMI. I was talking with the is it the World Diabetes Foundation you are working with? Yes, I said, yeah, we want to work with you too, because these are organizations that are representing the citizens or patients. So it's very, very important that we reach out to the citizens or patients and also the business sectors. But I want to take it a step further. Of course, with technology, we work with innovators, but I want to work with the inventors, investors, because the investors, they invest in money in startup capitals. What do they want to see happening? I think that's really also important. And that's why research becomes very complicated. We've been discussing that the research funding model is old. It's not working today, because you have to have this small research question, a small group of people you are working with. If we are going to have this broader perspective of collaborations, we need another kind of thinking when we're, funding research. I would like to emphasize the digital health literacy, and I think that's very important. And that's what I hear many people don't talk about. And of course, this is at different levels. The micro level, the citizens or patients, they need to know more about digitalization, digital solutions. But not only that, but also having the health literacy. I think for areas with chronic diseases, that's very important. That you know about your diseases, but also that the technology. And now we are moving into discussing the digital democracy being affected because of digital health literacy. So we are working on one of the unique big research projects is the EU project with 14 EU countries, was funded by EU Horizon, 2.7 million euros. It was the only one funded. So it will be ended in 2024. And we've been looking at to understand the first work to look at what is being done. How do we measure? Do we even know the level of digital health literacy in countries? Many countries in Europe, I think we found only one which had a national survey. We have no idea. And then we think that we are going to have digital transformation. We don't have so many people on board. And this is at all levels, the citizen patients, but also the workers within health systems and welfare systems, and decision makers. Then we go into the macro level, decision makers and politicians. And this has been discussed a lot, that politicians don't have enough knowledge about digitalization. And how are they going to invest in it and make right decisions? So I think this is an important issue, especially when we talk about implementation, because we won't be able to implement technology. So I'll end here. Thank you so much. I'll just want to highlight that we'll be running courses. This one we work actually with MOHAS, with Dr. Stumos, the first course, which my ambition that is going to be available to all research students who want to attend. And that's the beauty of digitalization. So this is going to be hybrid, which means that students like MOHAS, from MOHAS, they can be able to access these kinds of courses. So this is only the starting to see how we can do training in a different way. And accessibility is very important. And digitalization offers that kind of opportunity to see that we can have students, they don't need to be in the same room, physical room, but they can be in the digital room and acquire the knowledge that they really need. Asante sana.
Thank you very much, Professor Sarah Wamala, for a very nice presentation on digital health technologies, an opportunity to transform and strengthen health systems in Africa. I'm sure this has stimulated your minds in such a way that you definitely must have either comments or questions. May I welcome comments or questions?
I have a comment.
Welcome, please.
It's relevant. Thank you, Sarah, for this excellent presentation. And what I really like in this one is that you also involve not only academia and the others, but you involve the citizens and the users. And we had a long dialogue yesterday actually about one of these fields, which is the monthly period, which is a female thing. And of course, what you said yesterday, why are there not any females in the development of that I see around the table? That is my comment. Mix age, gender, religion, and make the best out of this. Because we put together end users, which could be a university, could be a business, could be something else, and we could get real users. Then we will invent the wrong things. That is my comment on this. So thank you, sir.
Thank you. Any other comment? Thank you, and please welcome forward.
Thank you, Professor Sarah. That was very insightful. I just want to add on to the challenge that we're facing, at least for us, in this part of the world. Even though we have not started fully utilizing digital health platforms and everything, we have one challenge: health literacy. Health literacy is a problem, and we know we are trying to address it, but we understand that even the knowledge and awareness is not good enough. So we have a challenge in health literacy. And then you bring into the digital development, the digital penetration into healthcare. Now that's another added challenge. One of the key things you mentioned here is that you actually it was a comment that politicians, the policymakers, they are not digital savvy. There's something you said, but I just wanted to point that when you look into this platform here, those who are here, you actually ask for who are the entities. Because we have a professor here. They're missing. And one of the disadvantages is actually when they develop these digital technologies into healthcare, they don't do it with us, the users. So please, if you could address how we can turn this around with all those that are mentioned. Thank you. Or in future, when you think of coming to us, think of all that scenario, and then how can we improve it? How can we, get the hanging fruits faster in our hands? Thank you. Thank you. Thank you.
Thank you for a very nice comment. Any other comment or question? Anything from the Zoom? Somebody monitoring? Any comments from participants in the Zoom? No.
Yeah, I have one. Can I ask?
Okay.
Yeah, thank you, Dr. Sarah. My name is Eden Matthew from Litri. Thank you for the nice presentation you've given us. I have one question. I was excited with your presentation, especially on the ecosystem perspective, where you presented the need for the collaboration for academia and the public sector. And I'm excited to see or to know if there is any paper which have the results to show how the collaboration between the healthcare industry and the businesses or the innovators or the private companies to sustain the model, because I've been in the public sector and in the donor community or partners community, and I think we've been approaching the healthcare digitalization from the partner government perspective, but little emphasis has been put on engaging the private or the innovation or the businesses. So I wonder if there's any country which has implemented that, or if there's any paper with evidence that we can learn and see how we can apply here in Tanzania. Thank you.
Thank you, Eden, for the question.
Very good question. Thank you. So scientifically, these are two models. We call it co-creation and co-production model. You remember that design thinking model I showed. So you are co-creating ideas around solving a challenge, right? And you end up with producing a solution. That's why it's called co-production. So there is actually a lot of some research which has been done on how co-production models should be applied in such research. And maybe I would say that when I meet my colleagues from the university, I've had the opportunity to work in all levels health systems and pharmaceutical industry. But when I meet my colleagues at the university, they've been working at the university 20, 15 years without, being exposed to other sectors. So it becomes difficult to know how are you going to evolve? Why should I even involve them? I think universities need also to find models whereby they can get their researchers, but also students. You can already start at student level to have students doing maybe master's thesis in an industry or healthcare system, and also researchers spending some time outside. That's the only way you can start to get closer. It's difficult when you have no idea how it works out there. but they are models scientifically which can be applied. Thank you.
Thank you. I think that was the last one. And before I allow Professor Sarah Wamala to go back and sit, I'm told there was no introduction of where exactly she's coming from and what is her interest, especially for those who joined us during this session and were not there in the morning. Sarah has multidisciplinary academic training that includes PhD in public health sciences from Karolinska Institute and has a master's in biostatistics and epidemiology from Stockholm University. She has a bachelor degree in economics from Makerere University and further postgraduate training in epidemiology and health economics from Cambridge School of Public Health. Sarah has also completed a postdoc at University of Otago, and actually her mission is to inspire as many people as possible to find unique inner power and utilize their full potential to live life fully and coordinate to making the world a better place. That is in a nutshell. So we can clap for Professor. Thank you very much.
Thank you very much.
Yeah.
Thank you very much, everyone.
So I stand to be guided. Are we ready for the panel discussion?
Why we consult about the grant? Any comment or question? I have one comment. Yesterday, I think about leadership, self-development, and one of the participants asked a question regarding what kind of skills and knowledge one need to have in order to be able to lead and also develop in a way that was defined as. And here from the CV of Sarah Wamala, one can see the example I was alluding to yesterday, that we should do away with the programming that we have been made to go through, that we need to make doctors, we need to make economists. And here we have one person who is economist, epidemiologist, doctor, everything in one person. So I urge the young people, you still have time to do that. You finish with IT, go for it. You finish medicine, go for economics. The sky is the limit. Okay, I'm told tea is ready, so we can break. And meanwhile, the panelists, I think, should prepare themselves. maybe we can say before they that we run we can look and let's be confident so that we come at the end. Thank you.
Hapa sina daktari yake mara hauna pesa. Mungu akilia kwa ama vile vingine vilikuwa nikienda mbele ya mwili kwa vile moja basi pambana tupike kwa inakuwa rahisi na basi tumaliza inshallah.
When we start. Good morning again. We're in the second part of the conference. And this time around, we have a panel discussion that will be comprised of 5 dignitaries. Mr. Silvanus Ilomo will be represented by Mr. Bagume. Please, you are welcome to take one of the front seats. Mr. Eric Kitali from PORALG will be represented by Mark. Please take a front seat. Professor Sarah Anderson. She will be joining us. We have Mr. Adelad Kiliba from GPITG. Do we have him around? No. And the last but not least, Dr. Heri Marwa from Farm Access. Please take the seat. So, let me give you a brief resume of the panelists. Sospita Bagume is a human-centered design with over 13 years experience in information systems projects, management and implementation. He's working with the Ministry of Health and has contributed a lot to the developing and deploying of the state-of-the-art ICT systems at national level. We have Dr. Heri Marwa from Farm Access. He is a health financing and policy advisor, working for 15 years in that profession. He's a qualified medical doctor
at the University of Dar es Salaam and holds a Master of Art in Health Policy and Financing. And he had that before joining Farm Access, where he's currently working as a country director. He has spent most of his career working as a senior manager at health insurance companies. And he also works as an independent consultant. While working with Farm Access, he has been involved in different projects that supports women and rural population in insurance issues. He had led projects that are aimed at providing micro health insurance for women, applying for micro loans from Pride Microfinance. He was also a team leader in designing and later piloting of the model for improving CHF in Kilimanjaro and Manyara, a model that has been accepted for rollout in the whole country in Tanzania. He was appointed as country director in May 2019, a position that he still holds. I don't think I need to repeat the resume for Professor Wamala, which I gave you early in the morning. However, I didn't get in time resume from Mark. Maybe I welcome him here to give you just a glimpse of where he is and what he is. You're welcome.
I greet you both with the greeting word of peace. In Arabic language, we say Assalamu alaikum. In Swahili, we say Amani iwe nanyi. My name is Mark. Coming from Purage. I'm a senior assistant journalist. And I've been working in this industry for about 22 years. Once I worked with the Parliament of Tanzania before going to Purage in 2016. As a system analyst, I've been developing some systems like Hosomis, which is running through the primary healthcare in more than 1,424 health facilities right now, meaning that we have 60 RRH, DDH hosts, so we have like 18, we have 803 dispensaries and health sector, in the health center, it's about 483, and in this hospitals we have like 111. Also being part of the system of planning and budgeting, which is Planner. So in brief, that's who is Mark. Thank you.
Thank you, Mark. And thank you for clapping, and I think this is for all of them four, and not for Mark alone. And if we start with our discussion this morning is about digital transformation and how it has how it will or can influence health system. And to start with, I think we shall start with Mark. The audience would want to know what's your opinion in terms of the relevance of this year's theme, which is attaining universal health coverage through digital transformation? Just to elaborate, universal health coverage underscores access to healthcare services through the whole continuum, from promotion, prevention, treatment, up to rehabilitation. And not only that, that those kind of services should be accessible as close to the people as possible and at a cost that will not impoverish them. That's, in a nutshell, what universal health coverage aims at. Now, this year's theme is, how can we attain universal health coverage through digital health transformation? Now, the first question is, how relevant is that theme, or this year's theme, in our current country situation? Welcome, Mr. Mark.
Thank you very much. Reach the use of digital transformation. So, you know, the digital transformation is about changing the action, modify the processes, or or use the new process. But with that digital transformation, we'll make sure that we have that switch there. Because through the use of digital transformation from the community level, for example, to capture data, plan to capture use data, and his data being accessible anywhere, and they could be decision. And through the use of the digital solution, people need to access information. Also, it will improve the information use, the data management, privacy, and security of it. It will improve the functionality of the information. Also, it will all involve use of the
Thank you. Mr. Bagume, how relevant do you think that theme is in our current situation?
Thank you. This theme is very relevant as far as digital health is concerned. First of all, let me give just a simple minor definition as I understand universal coverage. Universal coverage to me means access to healthcare without discrimination. And how do we go to reach this after healthcare discrimination? It's by the recent embarkment of the parliament by approving the bill which is signed by the honorable the president of Tanzania, which is all about health insurance for all, in my for this will be here in numbers of ways. The first way is having the insurance claims, relating to insurance claims needed to property to legal system. In order so that health facilities will be having their own funds for insurance in time, so that they can procure drugs, they can procure commodities, they can procure reactive for lab, so that they can complete the nature of hospitals and to proceed. Another way in which teachers is improving the process coverage is by reducing the time on time of lab research to patients. We need to see the time on time patient is reduced. Also, the patient waiting time is also reduced. The number of patients which can be seen per day in the hospitals can decrease by using digital systems. Because with the recent use of file systems, just the time to save one file, press file, time to move the file, and those files are many. For instance, Benjamin Mkapa was seeing less than 1,000 pages per day. But with the introduction of the digital system of the Benjamin Mkapa, they are seeing more than 2,000 pages per day. And so it's already the increase also the revenue of the hospital. I beg some me. Thank you, sir.
Thank you. Dr. Mara.
Thanks, moderator. I will have the pleasure to share the panel's some of the things. And the lecture on the student prevention on better vegan. I'm sitting in the board of Lucer with University College, and from my experience there, I learned that for students who are to be enrolled in AHIF as a mandatory enrollment, it usually takes them at least 3 months after the payment for them to get identification, the national identification, at least 3 months. And this is happening during the time when we know how the digital transformation can help with all these processes, including registration and identification and enrollment. If you want to understand how important digital transformation is in relation to this topic, you have to use that example. So I think to understand how relevant this thing is, first we have to look at those 3 components which are used at which WHO normally use to assess the success of the university in that field, probably most of you are aware, like who is covered, what sectors are covered, and to which extent the cost which is covered helps someone not to fall into the poverty. So if you look at all these 3 areas, you will find that digital transformation has a big role to play in all the 3 of them. Of course, I cannot go through them because we get like 2 hours to share examples. But if you look like digital transformation helps us to identify who are covered or to increase the number of those who are covered, definitely yes. There are examples what I just gave to identify who need to be covered. I think we all understand what happened a week ago when the parliament decided to take off the UHCD. And one of the reasons I had out of issue that so the challenge of how to identify what to take and how to take for them. And I think this is one of the areas where digital transformation can do a lot to do it in an efficient and effective way. We know countries who are using mobile phone data just to identify who are the poor, and then so that they can get the 100% of the poor. So that's the area where digital transformation can help. Looking at what is ours, I think there is a lot of applications. I think what we get some of the a lot of applications, a lot of initiatives, digital initiatives, which can help us to increase the services. You will be surprised in our country today. There is no any insurance company which cover telemedicine in their package. So these are the things which you expect them to see them first, because first of all, it's going to reduce the cost, it's going to increase the coverage. If I'm living in Tanzania, why should I come all the way here to do the test that the AKCI? Right, there's a regional hospital there where they can do the medicine there. So that's what increase the airport is covered. And of course, last in terms of cost, if you want to provide low parking spot, then you need to be say, because the increased transparency, it reduces the cost and increase it. So it's not there, and I probably share more.
Thank you. Professor Sarah.
Thank you very much. The transformation, like to emphasize the word transformation. Maybe this is what we do most of the time, that you are going to get a good health technology and just add it up to whatever you are doing, or you can give your solution to whatever you are doing. It's about a change, actually, change, both in the mindset and the way we do things. So that's important to notice. But I would like to draw attention on how COVID showed us the way that we've been waiting ourselves for implement now and we have seen how COVID has changed the issue of the distance working, distance monitoring and home-based care, all of things. There are a lot of possibilities how digital transformation has transformed the whole society action. Is everything from commerce to decision making, planning, regardless of which area, and analysis of imaging. I was talking to some students here who are looking at artificial intelligence and how to analyze quickly imaging or different kinds of diseases. This one was cancer, but it's being used in other kinds of diseases too. So there are a lot of opportunities with that. And of course, we should mention also digital robots. Robots which is becoming more common, and it's Amazon now showing that if you go to an Amazon bookstore or whatever they have, they started with books now, they have many other things you can buy on Amazon. It's only robots that work there. We are not human beings, maybe there's one or two to make sure that everything is moving and there are alerts what to do. They have just built a store close to my university. It's around 1.5 years. It's interesting. So then it's going to show thought that, oh, we are going to get another big take much more coming here. They're going to get videos. No. It was only 2 who were working there, the rest are not. So we need to think about the transformation. Then what are the people going to do from there? We use we need things and have them and send them. But of course, there are advantages that you will not have damages for the human beings, because that everything packaging has its own advantages. And another one is the education, e-learning. I think we have big wins on that also. Generally for mass education, but also for healthcare workers and also teachers. So we can use the e-learning to speed up the process.
Thank you, Professor Sarah. In fact, you have taken me to my next question, which was how can we take advantage of the experiences we had from COVID epidemic to be able to fast track digital transformation in the health services. Surveillance in particular. Dr. Maro?
I think maybe I can share an example of what I believe reached in Ghana, where the platform which was used to identify those people's symptoms of COVID and refer those to, because the platform where just key your symptoms, and then it will advise you whether to go to hospital or something which you can say at home. And now the same is used for NTB. It's a visual improvement, and now the same is but also from the COVID experience, the so-called the virus now around not about COVID only, but now the virus which was used for the COVID-19 is now used for all the emerging infections. So you can see that things which initially were used during COVID time, the digital applications during COVID time are now used for the support health system there. I think that's the two experience example that I shown.
Thank you, Mr. Baguma.
Thank you a lot, Moderator. I'm our professor. We laid a lot during COVID time. Police and application video system helped a lot to manage the COVID. From contact tracing, management of the COVID-19, until the in-time response of the COVID patients. Police with the COVID-19 Tanzania, we came up with various applications. We have FEMA COVID, we have Title COVID, we have African Safety, all of them have entire management of COVID-19 and also the contact tracing. Until when you realize not one was mission, but it's only the transmission. But also, we don't forget the contribution to intelligence in the coming up with the vaccine of COVID-19. And application of intelligence made the relation to come up with vaccination to be used to use time whereby vaccination will take in time to be discovered. But also I can just give up an example of the artificial intelligence scenario whereby it also include to attainment of SCP. For instance, when for the first time HIV patient reached the hospital, the doctor cannot detect, just using just simple time, cannot detect which this particular HIV patient is in which state or which HIV state. But once you have a tool for AI, you can put the symptom of this patient. The algorithm of the AI can learn and give you this answer that this patient is in this state of HIV. Apart from that, once the patient has used a lot of type of drugs, and they have just used go to the doctor can wonder which type of drug is just appearing with patient. But with the artificial intelligence, we have a tool whereby we put the type of drug the patient has used, the algorithm can learn and give you type of the drug class in which the patient is just arguing for the patient. And then can put the doctor in the present system to decide which type of drug to be given to this patient. Apart from that, also with coma patients sometimes they take a lot of time to evaluate a coma. But you actually put some tests to this coma patient, you can put them on the AI tool. The AI tool algorithm learn and can give you the prediction. Whereby in this type of clinical tool, or 2 months or 3 months, this person can just work out of the coma. Thank you, Moderator.
Thank you, Mr. Baguma. Let's AI replace the doctor. Mr. Mark.
Well, thank you very much. We will have today how digital transformation helps
And how can we use that experience to fast track whatever we want to do now so that we achieve more?
Yes, because that it's very easy to share information. Access to information was very important. Things because all of those for people that are already because during COVID is when the Zoom is in the Microsoft where was very much it was very productive. And you can also see how people help finding some online jobs. See, a lot of people that well looking from home that you COVID and that's still deliver, but also the case of students, also students, where they you can see that.
Thank you, Mark. This brings me to my next, my next question, where we take now on the direction of resources. How do you think we can use digital health to try and improve resource management? And here I'm talking about the whole process of procurement, utilization, distribution, along the whole chain. And let's look at all the kind of resources that are necessary and important in our health services. Take, for example, commodities. We have a severe problem in our country when it comes to ensuring that drugs are available in all the facilities throughout the year. Let's take example of human resource for health. We have shortages, and within shortages, we have maldistribution, where in some areas you have a lot of health workers, and in others you have quite few. And not to mention about finance, which already Dr. Mara started, the whole issue about how do we ensure proper management of finance that we have through digital health transformation. Who wants to start?
Yeah, so I think because of time, we forgot the of the component and then I think it's one of the surprising things to me is that while the people who are doing commercial business can order a consignment from India or China, and after 3 weeks he has a container already in WhatsApp and start using. For us, it can take 3 months to get the medication from India to once. You ask yourself why. If Alibaba can provide it within the consignment in 3 weeks, why do we need 3 months? And you ask yourself, do we still really need the central medical store with the current digital development? Does Alibaba has awareness? So if you ask those questions, that's where I realize where our challenges for most are. That's why years and years and years, since when I was in medical school, there has not been a year where a central medical store has got a clean audit report. Why we are not changing? I think the problem is with the mindset. So maybe I talk also on the finance, because that's the area where I've been working for 1 years. Looking at the whole spectrum of the finance, from the pooling, collection of funds, strategic purchasing, and payments, you find that one of the areas which can benefit mostly when it comes to solving finance. Because with the digital development, you can now ask someone who is sitting in Tanzania we pay insurance premium now, and that's a lot of collection. And then he gets his number and insurance card, even within 5 minutes. So that's how digital transformation can help us when it comes to the against. Talking of strategic perspective, we have seen recently, I'm not sure if you guys follow the stage report. In this era, we still have boys who are pregnant and the premium are paid by energy. And here we are talking about artificial intelligence. A student here who I met him in the, I think it's the last year Tanzania summit, is now working on artificial intelligence that knows cancer. And we have a government company which is still pregnant for quality, paying pregnant for quality. So I think there is a real potential, but the first thing to change, or the first challenge is not even about. The first challenge is how we change our minds. Again, looking at the payments, I talked about. So if you look at all the four spectrum for health financing, there is a very potential if this one change if we will need the digital transformation.
Thank you.
Thank you, Honorable. There are 3 levels of data use for related to resources. Tanzania as a country is a very large country. We've got more than 5 regions, and most of them, the distribution of West cities across the level of health centers, dispensary, hospitals, with more dispensaries in the health centers compared to hospitals and other nations. And most of these dispensaries are in hard-to-reach areas. Sometimes getting through that they need work commodities, the challenge. But in production, with EMIS, the logistic and independent systems are made it simple. The facilities can order and request the requisite as commodities within the system, the EMIS system. And just in time, just a week or a second, medical store department will get this request and can just start preparing the distribution will go to start dispensers. But we cannot forget that most of these dispensers, most of them, they have to reach area. So sometimes loads, the traffic loads, they are not there. So you can find that sometimes some loads are not even passable during lanes in the other area, in the other time. But medical service department is doing a lot. In the past 3 years, they are trying in order to distribute health commodities to a certain health facility. You have to make sure that before you distribute this particular facilities has to be having a dependency of finance to their account, the respective account, the medical department. Those are the challenges. But the government and national level will just push them to make sure that these commodities they are available. But the trend now has radically improved. Most of the they put the essential medicine and best medicines. So the trend now has improved. Let's compare to 5 years past. But I can also talk about the use of the data across 3 levels: health workers, health managers, at national levels. Health workers can use this data to make sure they improve that they use data their particular way. Health managers can also use data to make sure that they can plan and use the data to make sure that they make evidence-based planning their way. But also managers at national level, we can use the same data to make sure that you know the trend of what exactly for across the country to make sure that we have a big picture and when we do planning at national yearly planning national level, we do have a planning which uses evidence data. Those are the particular improvement which will make particular decades, 2 decades past. But before the 2 decades, the situation was the big issues. But now we've radically improved, and we are trying to use the foundation that they use by using digital systems to make sure that we sustain these improvements to the coming time. Thank you, Moderator.
Thank you. I've been informed by those who are following us through internet that they are not getting us well when we talk from there. Can I request, please, if the speaker or the panelist would come here and talk? It will be a bit of hassle to you, but bear with us.
Thank you very much. We are talking about the resource management. For me, I put it into 3 categories. We're talking about the human resource management. We'll be talking about the finance, and also we'll be talking about the drugs and the medical equipment management. Beginning with the finance, reflecting our own systems. I'm talking about PlanRep, the system which is for budgeting and the planning. Talking about Gotomis, and they're talking about FAST. FAST is the Facility Financial Accounting and Reporting System, which is being used by more than 29,000 health facilities and schools, which are being made out there for us in order for the facility to use the budgeted it has to start their planning. They will include their planning in planner to this level, and then the same budgeted projected budget should be sent to FAST, which is the Facility Financial Accounting Reporting System, which is there for payment purposes. And then you can use the money which has not been budgeted. So that's how whenever you want to do the purchase, you have to make sure that first it was planned and then it was sent to the payment system in the facility where that system is one which is used for payment. For example, when you want to purchase a commodity from MSC, Gotomis is being integrated with the MSC. Yes. So, for example, if you have out of stock, we always get out of notification from MSC, and then you could contact the private vendors. We have a JCR service in Gotomis, which is for private vendors. Whenever there is insufficient amount of drugs in MSC, they always go and order through the private vendors. So it helps, getting the instant notification if there is insufficient out of stock. And then to notify the facility in charge, and then it will be easy to order from the private vendors. But also, Gotomis is being integrated by GPG, the Government Electronic Payment Gateway. So any bills which is being paid through Gotomis system, it has to go first to GPG and generate the control number. So there is no hard cash at the facilities. So you see how these digital systems have helped to manage these systems. Thank you very much.
Thank you. Sarah, you want to add? Okay. Let me be a bit more focused now in terms of the type of information we need. We have seen, for example, with the resources, take commodity. The MSE, if you ask them, they will tell you we don't have good information for this. That's why we cannot respond promptly to that. But you go to the health facilities, you find lots of other challenges with the data that is being collected. Take human resource for health. If you ask today, much as we have a system, but if not, I want data on staff work for all the facilities, all the regions, all this, I cannot get it. Yet we want to manage human resource. And the platform is there. Go to finance, same problem. We have lots of platforms for managing finance. But Pilfrey is there. You gave a very good example. You have boys being attended with abortion. The systems are there. Now, the question is, how can digital health transformation help us to improve on the quality of data and information? And when I talk about this, one, completeness, timeliness, and accuracy. Because unless we have those parameters, then every now and then we will always be complaining that we don't have good information. That's why we cannot project. Can we start with? Oh, who wants to start with that? How can we improve our information system, health information system, to the extent that we can address the existing major challenges in managing our main resource, commodities, human resource, and finance? Thank you. I'm sorry, this second for you.
Thank you, Honorable Professor, and our moderator for today. Digital health implementation is a journey. Ladies and gentlemen, digital health transformation is a journey. We start somewhere, but with the aim of reaching somewhere. So we started by having a lot of digital systems. Then we put a governance in place to govern these digital systems by reducing the duplication of efforts and resources to make sure we implement the same scenario or thematic area of digital systems. Now, the question which Professor is asking here, how can we enforce data use to make sure that we use data use which is having quality? The data is there, the quality of data is there, the timeliness is there, completeness is there, and accuracy is there. Those are journeys which can be achieved at a branch of time and being achieved. One of the initiatives which we put in place to make sure that we achieve that journey is by inculcating the data use, to make sure that how can we enforce data use, for instance. Most of these medical practitioners, they finish their universities by not having the skills of data use. So how do we enforce these students when they are in universities to make sure they have the skills of data use? Is by making sure that we introduce these digital systems which are being used at the Ministry of Health and partners level to be at the university level, so that when they finish their university levels, they do have those skills, so that they cannot produce the data. For instance, a boy is having pregnant or a boy is having abortion. Those are some of the data use we are talking about. Apart from that, also you can create validation in the systems. You can create validation in such a way that whenever you put a boy is pregnant, the system can just alert you this is an error, so you collect it. Apart from that, also you can create the in-service and pre-service training of data use in such a way that whenever a student or medical practitioner is finishing the universities, they have got the skills of data use. For instance, most of digital systems which are being used by the Ministry of Health and partners, they can be introduced to the universities in such a way that whenever these medical students they finish their universities, they do have those skills of those such digital systems. Apart from that, also the 4 medical practitioners which have already finished their universities, they're in work. We can introduce the e-learning services in such a way that they can be having the studies of these digital systems which are being used at work and Ministry of Health and partners to make sure that they've got those skills. They got those skills to make sure they use data collectively and accurately. Those are my contributions which I can make at this panel, and I beg Sami to moderate. Thank you.
Thank you very much for the response. Dr. Maria.
Thanks. That's one. David, I think first I agree with the speaker that digital transformation is a journey. I think no one can dispute that. And it has to be a journey which you know where you're going. Because if you don't know where you are going, then you will probably not reach where you are going, or it will take a very, very long time to know where we are going. And lucky enough, I think Professor mentioned we have the digital health strategy for both Tanzania mainland and Zanzibar, which actually tell us where we should go. But the question is, how close are we following the implementation of the digital strategy? That's a question of other day. But I think, to my opinion, one of the challenge we have related to the how to improve the data use is that in most cases, we are using the data to tell us what happened, which is analysis, while others have moved from there, and now they're using the data to tell them why it has happened. So for us, if you look on the data we are collecting, take this into her book, it will most tell you what has happened, how many women have died. But I think we have to move from that and start to use data to tell us why these women have died. And that's the analytics. Normal analytics, you start with a problem and they use the data to find why it happened. But that's not what is happening. And as a result, you find that most of the data we are collecting are only used to share or to report. Recently, we had a mom care program, which capture 80% of what is captured in the this Mtuha books on a real time, updated after every 24 hours, and with the dashboards, a separate dashboard for nurses who are working at the clinic, a manager of the facility, a district, and a region in Manyara. And you know what's the percentage of, because we could monitor from the dashboard who are using the dashboard. Do you know what's the percentage of those who are using the dashboard from those people? Let's say from district and the regional office. Can you guess what's the percentage of those who are using the dashboard to follow what is happening at their facilities? Who can guess? It was not even 30%. Actually, not even 20%. I'll not give you a percent, but just know it was not even a 20%. And here are the people who are getting everything, as Professor Simba mentioned, data are complete because they are collected with the tablets right at the point of service. They were on time, 24 hours updated in the dashboards, but no one was using the data. But go to their monthly reports, everyone submitted them to her data which show what happened. So to me, the first thing to change is a mindset. If we don't change the mindset, we can invest, we can improve infrastructure, we can provide everything, but we will not achieve UHC if we don't change our mindset and address the use of the digital transformation to achieve the UHC.
Thank you, Dr. Marwa. Let's hear from Mark.
Thank you, Professor. To me, I've got like 5 things to talk about. First of all, we need digital solutions that are interoperable. This digital information and this digital system will exchange information between systems. And then we need to have digital solutions which are data-centric, meaning that we capture quality information from the right people. And then these digital solutions should be client-centric, meaning that these digital solutions could define the needs of the clients. And then these digital solutions will be flexible, meaning that these digital solutions should be flexible and scalable that would accommodate future requirements and could be enhanced to be added some other features. But we've been keeping blames on these digital solutions, but also I think we should focus on people. Change. People doesn't want to change. If you need to have a successful system implementation of digital solution, I always consider three factors. We have people, we have process, and then we have ICT. For me, people have 70% of the system to be successful. And the process is 20%. The IT is only 10%. So if you guys go on a change and they expect the technology to change you, then that's a problem. I remember one day I had a friend who is a doctor. I'm sorry, doctors. We had that solution which had a decision support algorithm. It was running a decision support algorithm. And then the doctor was told to use the system, and the doctor was like, it's not possible. So these things wants to be smarter than me. I spent 5 years in the university, and you only spent 4 years, and right now this thing is telling me what to do. So the thing is, it's not about how we capture, how we implement the solutions, but who uses the solution? Are they ready to use the solution? So that's the thing. Right now, for example, we still, depending on tour books, them tour books. But we have systems that could generate those reports. But people doesn't want to change. People are sticking to books. So that's the thing. So sometimes we might put a blame on systems, but the thing is we need to change the mindset, as my fellow speaker said before. Thank you very much.
Thank you, Mark. Oh, you're taking notes?
Thank you. Very interesting discussion. Of course, we can discuss this forever because there are so many things coming up, you know, and there are so many things to discuss. And when it comes to, for instance, patients and access to healthcare, so you are looking at monitoring, prediction, and what then next? So still we have issues with interface from the medical devices that are being used by patients. Well, I have this problem. I see my glucoses now are getting crazy. So what will be the next? So now there are some actually AI-based solutions that will alert the doctor to do something with the patient because, for instance, the glucose levels have gone up or CRP levels because of, showing infections and all that. So that interface is important. But again, as you were saying, and my colleague over there, that then the doctor need to think, I don't need the patient to come here, but I can maybe subscribe a medication. Paul, Joseph that I met yesterday is looking at how do you coordinate pharmaceutical products, and then you go into that. So it's a process. So if you do the monitoring, what happens later? And of course, we are getting into interoperability of the data that is being gathered, and there is a lot of data being gathered, but again, not being used. And if it's not used, it's a waste. It doesn't give any benefit at all. And of course, there are solutions. My colleague, Dr. Sukumos, has an article where he did a systematic review looking at artificial intelligence-based solutions in Tanzania. Very interesting. So he found 40 studies who have been using AI-based solutions, and 16 of them were eligible. So these systems are already there. And with the AI algorithm, you can move it to another area and feed in the data that way. So it's a matter of seeing, well, how do we scale up what we have in a way that can give more value and benefits? Thank you.
Thank you, Prof. And I think time is not with us. Let me give opportunity now to wind up from the panelists. If you could wind up by just telling us one major barrier that you think actually hinder us or is likely to hinder our progress in terms of digital health transformation, and what solution, if you can mention at least one strategy that we should adopt to address it as a take-home message. Whom do we start? Dr. Naro?
Yeah, I think one thing which we have to agree that sometimes the digital transformation can be scary. And you can imagine at some point a robot is asking you to confirm if you're a human. That can be scary. But I think still we need to change our mindset. I don't want to point to anyone, whether being a government, being a private. We need to change our mindset if we really want to take advantage of digital transformation to achieve.
How do we do it
now
at a country level?
Yes, so I think one of the things we have to do, we have to make sure that us as stakeholders, to ensure that we do the advocacy and we show those who are at the policy level to understand what are the advantages which will come with a digital transformation. Because if that's not the case, only disadvantage, which normally are the ones which we go out first, we hinder everyone to make sure that they go there. I give you one example. 2 years ago, a company a private company, I don't want to mention the name, established telemedicine, and they employed 8 doctors. I was a member of their board. After 6 months, they were asked to stop by government. You know why? There are no regulations. So which should come first? So if you look on those examples, and I can use 1 hour to give those examples, there is a need for the stakeholders to change, to do the advocacy to ensure that those who are sitting on the policy making side change their mindset and understand and take a digital transformation as something which is of advantage, as something which will reduce costs, rather than looking at something which will increase cost. Because yes, at first you need a lot of investment, but if you look 10 years after, you're probably going to reduce your cost by half. Of course, with efficiency and transparency. Thank you.
Thank you, Dr. Maro. We have a representative of the minister here. I'm sure he wants to go with a message to the minister. And if I should quote, at one time I was talking to one of the previous ministers, and he was talking like, I want to have data on whatever indicator that I need there on the screen. That if I'm talking to member of parliament, then he's asking me about X, Y, and Z. They just click there and I show him that. So that gives me an impression like, the mindset is there, but how does it calculate down there so that even the health facility in charge should have the same number? Who's coming next?
Thank you, Professor. With me, I'll stick with one thing, that let's stop working in silos. You know, we need to synergize all these digital endeavors to make sure that we do things in harmony. We refer to some examples. You go to the community level right now, see, you could find that the community health worker possess like 5 mobile phones. You know, every mobile phone running different application. You see, everybody who comes with his own intervention wants to run his own, have his own solution. But also, recently the government just decided that on the facility level, autonomies in the primary healthcare, autonomies should be the system which is being run to the primary healthcare. But aftercare should be the system that could run to the RRH and above. But still, as I was saying here, you could go to a place and find that these people are doing the health workers are doing the manual, them trouble, giving them troubles, while you have a digitalized system. But also, you could find that there's some other small system on the facility, which could only be a microservice on doing the vaccination and the stuff. So if you expect that mother, that worker who's working in the RCH, working with the governments, go working with the team vaccination, go working with the board, So it causes burnout to this. So for me, my advice is that we should synergize all the efforts. Use the infrastructure that I have at a certain facility. You know, you come out with the another solution. We use the certain infrastructure and the resource that you have. You help us come out with something which is really. Thank you very much.
Thank you. So if I understood you well, here we are. We have problems, some of them we already have policies and strategies that are not being well implemented. So perhaps the message here is that should be taken across. Let's go to the strategy that we set ourselves and see that they are implemented, because integration, I'm sure, is there in the strategies. Some of you will come here and tell us. But to what extent are we integrating? And to what extent does the government oversee that we are attaining that? I think that might be. Your turn?
Yes.
Thank you, Professor. The barrier to digital health implementation. The first barrier is called resistance to change. When you deploy your systems, people they don't want to respond to the new ways of digital health system they operate. But the solution to that, the first solution is to have the effective supervision of decision makers. Decision makers to effectively supervise the deployment of these systems, because once they order from the top, employee will follow from the bottom. Another solution is the mentorship, since sometimes they might be having lack of skills to operate the new system. So the solution that you have is having the mentorship, effective training. When you are commissioning the systems, you have to have the effective training. Apart from that, we have to do mentorship and support supervision, whereby you can make sure you assist them how to operate those systems in the daily work. Another thing, those systems that should be having the job, they should be at the level of job aid to them, in such a way that they should not act like they're having the additional work to them, but they should be acting like they are the job aid to those health practitioners or those staffs. Apart from that, also I want to respond to my friend Mwita, Maro, yes. He just gave an example that once upon a time they had a company which will implement medicine in the country, and when they started operating after 6 years, they stopped with the government. I'm sitting at that desk of telemedicine, the Ministry of Health. There are two types of telemedicine. The first type of telemedicine is provider to provider. The second type is provider to patient. The particular type of the telemedicine, which is technology in the country up to now, is provider to provider, in such a way that hospital to hospital, in such a way that a patient in a remote site, in a remote hospital, is having a doctor in his site, and they are contacting the specialist doctor at another level. With this provider to a patient, sometimes in such a way that a telemedicine site with a patient at a distant level using a mobile phone or computer, it is limiting some few issues which are very credible at a medical practitioner level. For instance, limit the physical examination of the patient. You cannot examine this patient physically, maybe you want to see the eyelid, sometimes the doctor wants, they do check the eyelid, sometimes they do check the tongue, sometimes they do check the body how, according to the professions. So it limits some of those. But it can be helpful maybe for patients who are going to refill the medicines, or they're not going for the first time at the medical to seek medical attention. So we saw sometime we should be having regulation in place, a guideline in place, which can guide and regulate this kind of services. And up to now, we have to go to any kind of the resources to make sure that we operationalize those guidelines. But those guidelines can check such issues like the data security of such a service in such a way that once those data are unleashed to the community and unleashed to the public, who should be blamed? Who should respond? And once the person is mistreated, who should be responsible at the court? Those kind of issues, they're paramount important to make sure that we also include them in the guideline, or to make sure that we advise accordingly these pioneers of telemedicine, so that it is being implemented according to the law of Tanzania. So those are the kind of the issues. But apart from this, I would like to commend that the two barriers which we do have is resistance to change, lack of skills. The third barrier, which is very critical, is lack of resources. For instance, the Tanzania digital strategy, we outlined a lot of gaps which we saw. These gaps should be implemented within 10 years to come. But until now, I think we are in the midway, but a lot of gaps have not been implemented. And we defined our requirement in Tanzania to so-called Tanzania Investment Roadmap, or Tanzania Investment Recommendations, to make sure that whenever a donor comes or whenever a partner comes, it should not come and define what should we do, but we can tell him, hey, these are requirements. We expect to do them in coming 10 years. So once you want to do, you can choose among these requirements and implement. This actually, it put the government to be in a driver's seat in terms of implementing digital strategy. Apart from the donor-driven approach, which has happened in far back years. So up to now, I think the governance which you have, the document which you have, they put us in a good way to put the government in the driver's seat in terms of digital implementation. Thank you, Madam.
Thank you. Last, but not least,
Our
take-home message.
Take-home message, I think my colleagues have said that it's more starting the change readiness process at all levels, micro, macro, and meso level. So that's important. And another thing is to understand the context. My colleague, friend, Dr. Holpani from the ministry was talking about the context, to understand the context. Many technologies come from other countries, and in order to implement them need to be customized. Capacity building is important and is needed. So at all levels, so that will be needed, absolutely. But the citizen engagement is important. And of course, the digital health literacy also comes in, but also digitalization at large. But one should not underestimate the issue of both software and hardware, the devices, smartphones. You know, how many people have smartphones and they can afford them? Computers, iPads, and then internet access. How is it for everyone? I mean, if it goes up and down, it's not there, and you have a monitoring device is dependent on the internet, then that's gone. Maybe that's when it will come, the high peaks which you need to look at. So I'll just conclude by that, and of course the leadership and governance of how those should be implemented and rolled out in communities. Thank you.
Thank you very much, panelists. Let's clap for them. And this brings us now to the presentations. We have 4 of them, 15 minutes each. And I trust that during the presentation, they may also want to address some of the issues that they didn't have much time to clarify. So in the interest of time, let me welcome Mr. Bagume, who represents Silvanus Ilomo from Ministry of Health, to come and talk to us about the Tanzania Digital Health Strategy. Okay, good.
I think it's here. I think it's here. Don't. I think it's here. I put it here. I think it's here. I put it here.
Welcome, ladies and gentlemen. This is my presentation. The title goes, the highlights of Tanzania Digital Health Transformation Journey. We started from 1999 until to date. In 1999, we did have telemedicine implementation, but the disadvantage of those telemedicine implementation is those equipment were situated at the post offices to be communicating with hospitals and offering telemedicine service to the community. So we learned from those approach. Nowadays, we do not situate the telemedicine equipment at the post office. We situate them at the hospitals so that patients can conveniently see the specialists at the remote site and get the telemedicine services. In 2000, we approached him to apply. Tour was implemented, was introduced. DHS2 was forward, CTC card was forward, the MH, the Ministry of Health and Security was introduced in 2006. DHS2 was forward also, and the other information system was forward. So during this decade, we characterized by the introduction of the information collection in the Ministry of Health. And it was also this period whereby the call for governance of digital health systems was climbing, because most of these systems which were introduced during this decade there are no coordinated and governance structure which can connect these information system initiation in such a way that there are a lot of duplicates which were being introduced in the country and silos was being introduced in the country. So the coming decade, the decade of 2011 to 2020, we introduced the governance structure which was being illustrated in the Tanzania ES strategy, whereby it was as part of those ES strategy, we introduced the governance structure called it, baptized this as ES steering committee, in which whereby any information, any digital system in order to be introduced at national level, it has to pass within the ES steering committee so that they can give the clearance of those initiation to proceed. And this was so because it was tricky to be controlled by the ICT unit because most of donors sometimes they do meet the president, the minister of health, they meet the president when they visit the abroad, and when they come in the country, they tell you, okay, we met your president at Washington, we had dinner with him, we are going to implement this solution. So you, as just a me as a student here, you cannot argue anything. It's not a statement. But once it is placed under the mandate of the ES Steering Committee, which is chaired by the Permanent Secretary, Minister of Health, and Permanent Secretary, P.O. Large, and most of the CEOs of the ES department and the agencies, the members of such a ES committee, they can argue and see if it is credible to initiate such a initiative, then they can allow it to be initiated. With such a governance structure, we manage to control the initiation or duplication of efforts and resources of such silos. And also in this decade, we managed to initiate most of the supply chain management efficient systems, such as LMS, VIMS, and MSD, and most of legal systems like Gotigo Mission, Afakea, and TIMD. In 2021 to date, this decade, we introduced the enterprise architecture, which is a blueprint which put in place standards and protocols to make sure that whenever the system is introduced, if it has followed this EA blueprint, then this system can be interoperable. So from 2021 to date, we are maintaining the achievement which has been achieved in the previous decade to make sure that we sustain this achievement to going forward. What is our vision and mission? Our vision is to be, and our vision is where do we want to go actually? So where we want to go is to have the better health outcome through a digital enabled health systems. And how do we achieve it? Is this the mission? We achieve it by to accelerate the transformation of Tanzania healthcare systems through innovative, data-driven, client-centric, efficient, effective, and integrated digital health solutions. We did have some 5 strategic goals. I just mentioned the 2, others we just lead them. The first is to strengthen digital health governance and leadership by having the ES Steering Committee or Digital Steering Committee, and improve the client experience through efficient provision of high quality health services. Let's see some key achievements which we have achieved. The first achievement, we've established and strengthened the digital data governance mechanism, structures to oversee information. The second achievement is strengthen availability and use of waste supply chain data through digitization of commodities and logistic management. By having, for instance, the VIMS is vaccination management information system, a system which can manage and control all vaccination in the country, from the cold chain level to distribution of vaccinations. Also, having the EMS in place. EMS is electronic logistic management information systems. It controls the requisitions and distributions of health commodities across the country. Another achievement is improved data in key sectors in such administrative and management functions, including planning, financial management, supervision, and performance management. In planning, police will do a plan lab across the country, whereby all the plans are being put in a central way, are being put in the system before the year starts. And across the year, these plans are being implemented according to the plans which have been approved. And financial management also we do have MOSA, which is replacing Epica. Epica was a vendor-driven system. They called I've just forgotten the name. But Epica is a vendor-driven system. So we are just replaced it with the MOSA. MOSA is a system which a financial system whereby it controls expenditure, planning, to the distribution of funds across the country. It is it call about the central visibility of financial system, financial resources across the country. But also we do have the GPG. GPG also it calls about the central visibility of all expenditure in the country and the collection in the country. So all the decision makers they can see how much their organization they've just collected and how much is being distributed across the through the expenditures. So these are some of the key achievements which we have achieved. Another achievement is the information exchange between digital systems in the country based on sound-based and health information exchange layer. We have introduced a Tanzania health information exchange in the health sector called the health information mediator, whereby systems talk to each other through this layer, which is called the health information mediator. Up to now, we have more than 30 systems which talk to each other in the country, in the sector, in the Ministry of Health, and also in the PLR, they also do have the can you remind me, Mark? Yeah, they do have Muungano Gateway as Tanzania as a health information mediator in their side. And also across sectors, once you have cross sector from health sector to other sectors, we do have the Enterprise Service Bus, ESB, which is being driven by the e-government authority. So in the area of the interoperability, we have achieved so far. And this, what advantage do we have? For instance, this introduced some few advantages. For instance, one of the advantages in creating the full source of information can be based in a particular system. For instance, information about the registrations of health facilities in the country, they can be bought, they can be obtained from the HFR, Health Facility Registry. And those can be reliable information about the introduction of health facilities. And we cannot rely on any other information because this is a true source of data according to the Registration of Health Information Systems, in such a way that whenever DHS2 and all other systems, they want to know the existence of health facilities, they can just pull from the health facility register through the health information mediator. And this also another advantage is you can use data many times, and you can create data once and use this many times. You can create data once and use it in multiple times in such a way that when you create health registration information data in HFR once, and you can use it many times in VIMS and DHS2 and the other systems through the health information mediator. Notable gaps and challenges. Challenges, we do an availability of individual level data at national level, which can support effective monitoring and surveillance. For instance, we do follow the WHO standards whereby we do not allow the health information data from this facility to be shared as it is at national level or to other levels. And if you want to do so, you have to anonymize this data to make sure that they don't have the names and the other identifying informations. But with such a level, with such a trend, you can make sure that you limit those data, for instance, whenever you want to do contact tracing at national level, for instance, with COVID-19 pandemic, for instance. with COVID-19 pandemic, for instance, you can make sure you can find yourself that you cannot do contact tracing across the country at the national level. But with such a scenario, you can share identifying informations which you can separate identifying information from clinical informations. For instance, with introduction of the National Health Current Registry, you can share identifying information in National Health Current Registry, and the clinical information can be obtained from the clinical systems in such a way that with the National Current Registry, those information can be limited to meanings. For instance, you can find that the owner of the unique IDs can be shared across the levels. And also with this, with the second one, the second gate challenge is inability to uniquely identify health services clients. We do have the inability to uniquely identify health services clients, for instance, across the country. For instance, once I'm being treated in Mala, they see I have malaria. And once I come to Tabora, they see I have malaria. I go to the facility and they see me I have malaria. And once I come to the restaurant, maybe I go to the facility, they check me, they got me also have malaria. The malaria program, once they want to cross-check across the country, how many patients they do have of malaria, they see these 3 instances as 3 patients, but why is just 1 patient? So with these trends, you can find the planning of health commodity across the country yearly. It can affect it. Let me give a live example. For instance, with ARV, we do use ARV in the country, sponsored by SPEPFAR. But once we order this ARV before the year, we order ARV according to the number of patients we do have in the country. But there is one thing which can affect these trends. Other countries bordering Tanzania, like Congo and the other countries, don't get the pay for support. So truck drivers from Tanzania to Congo who have got the HIV, they do take this ARV in the country, several doses, and they go to sell it across Congo and the other countries. So they can, once they live here in the restaurant, they can go to Mwananyamala there, they got there, at the CTC clinic, they got the ARV dose. And once they just border into Kiba, they got another ARV dose. Until they leave the country, they've got maybe about 30 doses of ARV. And once they go to Congo, they say these ARV doses because there they don't give paper support. But why this is happening? It is happening because we don't have a unique identification of clients across the country. But listen to the national NSCP, National AIDS Control Program, the program which is responsible for HIV in the country. They've come up with the initiation to introduce National Health Current Registry to uniquely identify health clients in the country, such a way that when the medical HIV patients go to move from the first clinic to a second clinic, and what take the same dose in the same month, the system can determine and see, they say that you're taking the same ARV dose in this month, so you cannot be given another ARV dose. So such systems, we need them in place to control the lack of resources in the country, which are being contributed by just such a fraud like this ones. Another challenge is inadequate health workforce capacity to effectively use tools and data. This is concerned about data use, and I've just spoken about data use in the panel before. Another tangible challenge is lack of adequate resources to support implementation of priority areas in the strategy, digital investment roadmap. I just show these some of the areas whereby which they don't have any resources as far as the Tanzania investment roadmap is concerned. And I call upon donors and partners to collaborate with the Minister of Health to make sure that we implement these areas which don't have any support in the country. Looking to the future, what do we envision? We envision to improve coordination investment and implement digital health initiative in the systems. And also we do envision to mobilize resources to support the implementation of the entire digital health investment roadmap. Another envision is to document and share lessons local and global from Tanzania digital health investment transformation journey. And also we do wish to continue implementing appropriate change management strategies to sustain digital health investment, because change investment strategies, they ensure successful deployment and implementation of the information system in the country. Also, we do wish to advocate data use across levels for evidence-based decision support in the actions. I was speaking about data use in the panel before, so I don't want to repeat again. Area for collaboration, which you call upon donors and partners to make sure that we welcome you, the Minister of Health, Tanzania, both pure large and Minister of Health, to implement the following areas which actually they are not yet implemented in the country. The first one is to institutionalize the Center for Digital Health to fast track the e-health using emerging technology like AI, blockchain, and the others. We will introduce the Center for Digital Health in the country, which will be responsible for implementing artificial intelligence, blockchain, and other technology like big data analytics and other emerging technologies in the country. The center is built in Dodoma, and we call upon partners to join hands to support the Minister of Health to utilize the entire and tap upon this responsible advantage which can be tapped from the AI and the blockchain and the other emerging technologies. The second one is to finalize development and implementation of national clan registry. This is also a hanging fruit which can be tapped and be finalized. Another area which has not been touched at this time is implementation of the shared health record. Some people, they know about shared health record, so it's not yet implemented in the country, and we call upon partners to join hands to make sure that we implement this shared health record. Another to build the capacity in digital health and project management. Build the capacity of the ICT directorate in the country, both pure large and Ministry of Health, to make sure that we equip them with necessary project management skills to implement projects. And as you know, ICT is a growing cadre. Once you've learned ICT in 2007, it is not the same at this particular time. So we do want this ICT staff to update them, to update their knowledge, to make sure that they go at the pace of the technology in the country and globally. Another area is to implement integrated e-referral for clients and lab specimens. Another area is to implement digital platform for managing client feedback. Client feedback is a center for improving performance of health staffs in the country. So we want to tap on this potential area to make sure that we improve performance of health services delivered in the country. Another area to strengthen the national data warehouse. We want to strengthen the national data warehouse. We do have DHS2 as our national data warehouse, but we do want a complete and comprehensive data warehouse in the country. Another area which is not tapped yet is implementation of terminology services. So these are some of the areas which I can just mention quickly. We do call upon partners and the donors to come and collaborate with the Ministry of Health to implement these areas. Otherwise, I would like to thank you, ladies and gentlemen, for listening. Thank you very much.
Thank you, Mr. Bagume, and let me welcome now Mr. Mohammed Al-Malazi from the Ministry of Health, Zanzibar. Mr. Al-Malazi is the head of ICT department in the Ministry of Health, Zanzibar. He is in charge of ICT development. And he has been involved, actually overseen the development of the 5-year Zanzibar Digital Health Strategy running between 2000 and 2025. Mr. Al-Malazi is working with the Ministry of Health in Zanzibar. Before that, he worked with Danida as ICT technician. And he has a master's in information technology and currently is a PhD student in the same discipline. With that introduction, let me welcome Mr. Al-Malazi for the presentation that will take us some 10 to 15 minutes. You're welcome.
This one. Thank you so much for this opportunity. Let me correct, my name is Mohammed Al-Mafazi. We have those complicated names from Zanzibar. So my name is Mohammed Al-Mafazi. I'm a head of ICT department for the Ministry of Health Zanzibar. And I'll share with you the implementation of digital health strategy Zanzibar, the priorities, the progress, and challenges. First of all, let me take you to the background of the digital health strategy Zanzibar. Zanzibar has started the use of digital systems since early 1990s, when we had still those black screen disk operating systems for those who were in digital on those days. There are a number of initiatives that are being implemented since that time, including personnel information system, integrated human source information system, wired mother, telemedicine, and many others. But many of those initiatives were in ad hoc. They didn't have a clear direction, and it was difficult to sustain the initiatives. As a result, we had a number of challenges, including existence of multiple similar systems working in parallel, lack of infrastructure, lack of harmonization of different initiatives, overload for providers, as we know that Zanzibar, like many other African countries, we have a shortage of staff. So health providers used to be given multiple systems working and spend a lot of time in pushing data rather than taking care of the clients. In response to that challenges, Ministry of Health decided to develop the first digital health strategy, 2020-2025, which aligns with regional and international initiatives, including WHO Global Strategy on Digital Health 2020-2024, WHO guideline, which recommends on digital interventions for health system
strengthening of 2019, WITI National Health Strategy Toolkit, East African Community for Digital Health and Interoperability Assessment, the Digital Regional East African Community Initiatives Strategic Plan 2019-2028, but also the strategy aligns with the national initiatives, which include Zanzibar Vision 2050, Zanzibar Health Policy 2011, Zanzibar Health Sector Strategic Plan 4, Zanzibar ICT Policy, Zanzibar e-Government Policy, and Zanzibar Community Health Strategy 2019-2024. So the vision of our strategies are appropriate digital health solutions for better health for all Zanzibari, where the mission is to strengthen digital health enabling environment to support the implementation of interoperable systems for better health outcomes. And the overall goal, which aligns with the Ministry of Health goal, is to improve the provision of safer, equitable, accessible, efficient, and effective health services at all levels through proper use of digital health technologies. So after developing a strategy which consists of 8 strategic objectives, so the 8th strategic objective was mapped into 4 investment area, which is institutionalized digitalization of governance leadership. When in the assessment, we found that one of the gap was governance and leadership. So the second investment area of critical enabling systems, enabling foundational systems, then transformational systems, and the 4th is institutionalized accountability and health data for decision making. Also, we identified 4 priority areas which were supposed to be implemented sequentially, though unfortunately because of resources, we couldn't follow the sequence as was supposed to be. But the first at the left is a prerequisite, which is preparing for and setting the enabling institution for implementation of digital health strategy. This includes the development or creation of digital health department, which is supposed to oversee the implementation of the strategy, but the steering committee, which oversight the implementation itself, and the technical arm of the steering committee, which is digital health technical working group. And then the second part is foundational systems. These are different registers, which include client registry, the health facility registry, the terminology registry, and all other registries. The third area is transformational systems, which include the systems that operate at client level, which includes electronic medical record, the EDSR, and the other system that at the client level. And finally, the value add. This includes the data use, the development of data warehouse that will enable to collect various systems data that will be used for big data analytics for decision making. After developing the roadmap, we worked door by door to find support to implement the strategy. And these are many implementing partners, donor implementing partners that we are participating with in this implementation. That include Danida, D3, Farm Access, Global Supply Chain, PATH, PS3+, UXAF, and World Bank. most importantly, as of now, we have 72% commitment in the implementation, and we are still looking at 28%, which includes a number of initiatives that have got interest to support. Let me take you through the individual initiative and the progress of its implementation. Like I said, the first block consists of 7 initiatives. First is the establishment of a digital health department. This has only gone 10% so far because which includes capacity building of ICT staff in the department, but the department is not yet created because it requires a high-level decision. Second one is support the establishment of Zanzibar Digital Health Steering Committee. This is done, and it has so far continued to meet and make various decisions in the digital health implementation. It has covered 28% so far. Then the technical working group is working fine, which has covered 76% so far. Then interoperability layer is almost 85%. Enterprise architecture is almost covering 85%. What we need now is to take it through the high level for officialization. Development of health data protection and sharing framework. This is 100% done. The document is ready for use. Also, development of digitization transformation guideline is also completed, and the document is ready, and we are using it for implementation of this strategy. The development of interoperability layer, it's already covered 65%. And as you know that it goes with different identified use cases, and whichever use cases is completed is being used. So we have covered 65% so far. The second block is made up of 6 initiatives. Implementation of facility registry, this is not yet done, although the commitment is already there. It was supposed to start in the second year, but because of commitment of because staff are the same who are working various initiatives, so it's supposed to be starting soon. Implementation of health plan registry, it's we have 22% covered so far. Implementation admin area registry is not yet, we don't have commitment for implementation this one so far. And the implementation of health terminology services, not started, and we don't have funds for this. But implementation of health product catalog, we are working with global health supply chain, and we have covered 25% so far. Implementation of health worker registry, this is not yet started, and because we don't have resources for it so far. Then another area is implementation of planning reporting digital tool. This is completed. Actually, at the beginning, we thought that this plan rep would be useful for Ministry of Health only, but we went even beyond our expectation, because instead of being used only at the Ministry of Health, this planning reporting tool are used nationally at Zanzibar. Then implementation of hospital and primary healthcare level services. This is electronic medical record, and the coverage is 42%, because we have covered 5 district hospitals, and we are gradually moving one by one. At that first level hospital, which includes PHC and PHU plus, we have covered only 20%. As the system is ready, we are now waiting for tools and resources to deploy the system in different facilities. Digitization of health facility assessment and quality improvement process is 45% covered, because only few facilities are still using the system. So we are gradually roll out the system for the rest of the facilities. Enhanced system for management and health supply chain. We are working with global health supply chain, and the coverage so far is 55%. Implementation of community-based health information system. This initiative, we are working with D3 International, and the coverage is 60%, as we have some services are not yet included in this system. Digitization of integrated health surveillance system. This is electronic integrated disease surveillance and response. We are working with MDH, and the system is ready for use. A training has been done. Just we are waiting for deployment of the system, and we hope in 1 month's time we'll have this system running. Finally, we have implementation of Zanzibar integrated data warehouse. This initiative is not yet done, not started, because we don't have resources for it. Then strengthen telemedicine. We have 28% covered, because we wanted to roll out system at all district hospitals. So far, under the support of UCSAF, we have started Abdallah Mzee Hospital and Mnazi Mmoja Referral Hospital, along with Moi and Jakaya Kikwete for 2 services only, cardiology and orthopedics. So it is 28%. We hope that all the new built hospital will use the same system. Then implementation of digital solution for health promotion, and implementation of digital solution for client feedback is not yet started, because we don't have secure resources for these 2 yet. Now let me show you the coverage in general. We have 5 initiatives that are completed. We have 12 initiatives that are in progress and in a good progress, because most of them are over 70%. And we have 32, we have 8 initiatives not yet started for various reasons. So that shows that 20% is completed, 48% in very good progress, and 32% not yet started. Yet we are in our 2nd year. We hope that we will be able to complete the implementation of this strategy in less than 5 years planned. So we have some expected outputs, which includes health service performance. Using these systems, we believe that the health service will be having performed health services. But health provider accountability. For example, since we have started using electronic medical record, we can be measuring the performance of individual staff, but reliability of data. We can be able to collect a real-time and reliable data for various level decision-making, but improve quality of services and reduction of disease burden that will enhance the healthier community that will contribute to the country's economy. Let me tell you about some achievements. With implementation of digital Zanzibar electronic medical record, health service performance have improved. For example, from Pemba now, all the hospitals that have been implemented electronic medical record, a client can go to one hospital and the information can be retrieved on the different hospital that they are using the electronic medical record. So it can be that the continuity of service of patient is monitored very well, and the quality of service is being improved. But the health provider accountability, every staff now can be monitored what have they've done for the clients. Control of resources. We have been with the visit last month, and we visited one of the hospitals in Pemba called Vitongoji. They've said that since the usage of the system now, the stock of the supplies persist differently from how it was before. But another area is open IMIS, and that aligns with the theme of this meeting, the attainment of universal health coverage through a digital transformation. With open IMIS, we have been able to analyze the data, the service utilization, and the result was used to make the decision, the government decision on using using the insurance for all in Zanzibar. But planned, like I said, now is used across the country, but also we have with interoperability layer, now we have a health share record, and we are using the data that being collected from OpenIMS and is pulled as a registration data and minimize the time while registering the client in EMR in the first time. We still have a number of challenges, which includes inadequate infrastructure and tools for implementation of digital health strategy, the inadequate resources to implement routine and continuous ICT activities, overlapping of some responsibilities. We still have a weak coordination in the implementation of digital health strategy, but shortage of ICT staff in number and skills. And we still have limited awareness of the digital health strategy and its implementation among our leaders, which hinders sometimes the speed and the spirit of the implementation of the strategy. Thank you so much.
Thank you, Mr. Al-Malazi, for a nice presentation. And let me now welcome again Mr. Mark from PORALG to come and present to us primary health care digital transformation in Tanzania, priorities, progress, and challenges. You have 15 minutes.
Natumaini amani imetamalaki. As once I introduce myself, my name is Mark. I'm a senior systems analyst from PORALG. Because I'm here on behalf of Mr. Eric Kitali, who is the director of ICT department at PORALG. My presentation, of course, is a presentation, but it's somehow I'm sharing, because we have a new document, which is a PHC roadmap. So it's kind of presentation or kind of sharing with the people. So I'll be having very few areas to talk about. So hopefully it'll be very, very short presentation. So we talk about the national primary healthcare digital transformation, which is the use of technologies to achieve better health outcomes. Our vision is to is a digitalized PHC for better health outcomes. So when we the solution that we have been developing right now, if you want to measure its achievement. Can we say right now, have we registered less number of maternal mortality? Have we registered less number of death of children under 5? Have we improved the client's experience of care? What about the time that takes the client to get the health service? So when we speak about the better health outcomes, I think you should consider some of those things. But during this transformation, we, as of PHC, the digital transformation of PHC, we had some guiding principles. You know, wherever you want to come out with a new solution in the primary healthcare, we had some guiding principles. That is your solution interoperable. Can you exchange information with other systems? For example, right now we have autonomies out there. Autonomies right now has integrated with so many systems. As I've mentioned in the area, we have ELMIS, MSP, the GPG, NHAF, CHF, and so on. So, and right now we're trying to implement that standard. Requires that it's one which required, but most of the systems are still using the customized standards. So another guiding principle is the information security. For us, we need any system which runs yes, the information from the government that system should be hosted. One of the government friends. It's just a way of trying to make sure that we secure our information. Another thing is the use of open resource. That's another guidelines. Of course, we could use these open resources for learning, exchange for having informations and so on and so on. But also these systems that could be implemented should be data-driven systems. That means the system should focus on ensuring that the information are correct and they are going to the right people. But also another guiding principle, it should be client-centered. That the system that we are trying to develop, the solution, the digital solutions, to focus on solving user problems. Not having a system but it does another thing while the user does another thing. But also we need systems that are flexible, that whenever you need an improvement of the system should be flexible and scalable. That means when you need to add some other feature within the digital solution that you have just developed, you don't need to come out with another solution. Then you should use the existing solution to enhance the features that you want, that is they're absent for the existing systems. So after going through the guiding principles, then we have some priority areas that we focus. We have the data governance and the quality, the PHC digital systems, we have the integration with the key digital systems that we have an EMR system, speaking with the HS2, meaning that visualize data from the Sanity tool to the HS tool. But also the digital and data infrastructure. We have the information system rollout, but also the health workforce. And this will be described in the coming slide. So to be specific on the aforementioned priority areas, then these are the areas that we have primarily these are areas you can see on priority number one, number one, to create the learning governance for the digitalization and priority two is for possibility practices to strengthen the use of the PhD and data. This falls under every priority area in one which governs. And the priorities beyond priorities each one. This whole the element which is about the digital security, incorporating requirements, incorporating the PhD. The only thing we want to allow us to operate the EMR system is the automation. Also need to go on the mechanism for the hearing. But you know, our facilities have very, very low system balance. You could go to a facility and find that you only have one staff. The staff is doing the legislation, he's doing he's a nurse, he's doing the triage, he's acting like a doctor, he's really acting like a nurse, he's giving medics and everything. So we have an initiative of developing the low resource autonomy, where it would only use one gadget and access the system, and that system syncing the central authorities and all the information that have been captured from that low source center goes to the central. So these are some of the priorities that falls under the priority areas, that those 6 priority areas that I mentioned. So you could see that we have integrated PHC digital systems with the community health digital system, equip PHC facilities with the sufficient computing equipment, and this falls under the infrastructure. Implement networking infrastructure. We know you go to a facility and you find that there is no local area network. So there's no way you could install your system at that facility. So obviously you need the resource to implement the local area network first, so that the system could run at that particular facility. Then to implement last mile connectivity for PHC facilities. This means to communicate with the central server, using the PRH one. Because PRH has wide area network which connects 184 district councils. District municipal, local government authorities, the LGA, to have 184 LGs connected to PRS. But also we have 26 regions connected to PRS. So when we speak about the last mile connectivity for these facilities, we mean connecting these particular facilities to the HQ, which is the PRF data center. But also to provide a resilient data storage and backup infrastructure to PHC facilities. So that's where sometimes it's very expensive to have all these things at the facility. So that's why if we could get the national connectivity to PRF center, for function how we get the recoveries, the national internet, it takes it sends data after every 30 minutes. So if you could connect this facility to the Orange, and you know, this facility would access this system central and PRS, and it could store the data to PRS. That means the facility data would automatically be sent to the NIDC, which is PRS recovery data center. Another thing is to develop PHC digital system rollout plan. Of course, we need to have a rollout plan for Gotomis to deploy PHC digital system based on the rollout rollout plan. To build the capacity of the system users at all levels. Right here, of course, if you, for example, right now we have installed performance in 1,404, which is we have 6 regional hostels. Regional hostels, we will have 111 district hostels. We do have 806 dispensaries, and we do have 483 health facilities. But also we do have village hostels, which are 18, and that's makes it the total of 1,424. So you find that sometimes they use it. You go to a certain facility and you find that it's working, the people is working hard. But when you go to another facility, they have challenges. And sometimes it's not because we have a problem with the system, but it's because the users haven't been capacitated in a way that they could manage to run those business. But also to build the capacity of the system developers to adopt the standards based on TZ. We have the Tanzania Healthy Enterprise Architecture. So we have these developers developing this digital solution. So we need to capacitate them. For example, right now, we go Tanzania Healthy Enterprise Architecture. We find that we are supposed to be using the fire standard or HF7 standard. So we need to make sure that these people are capacitated so that whenever they develop the solution, they could use that solution for the interoperability. The challenges are the infrastructure have been our main soul, and this chorus, I think you go everywhere, people sings it very, very well. So infrastructure is a problem, specifically in the rural areas, but also the change and adoption. People tended to resist it to new solutions. This is change management. But also the shortage of staff, including service providers and the information and communication technology technical staff. Of course, we have solutions running into some facilities, but if you could go there, you could find that some facilities don't have an IT personnel that could help people to, as they face technical problems with the certain facility. Sometimes we get a data personnel to do the job. So we could see how difficult it is. But also to have unstable power supply. Maybe, we don't know, with Mwalimu Nyerere, well, Mwalimu Nyerere maybe could solve this thing, I don't know. But this is the main problem. You find that people are not using the system just because there is no power. This I've said it, Gotomis have been installed, these are achievements. Gotomis have been installed in 424 facilities. It has been integrated with so many systems. There have been an improved data quality and the availability. There have been an improved management and availability of healthy commodities, because we do have client trackers. We could track medicines, we could track our patients. But also there have been an efficient healthcare delivery at the health facilities. There have been an improved quality of care and enhanced the healthcare performance. But there is an ongoing development of low resource Gotomis that I was talking about for the low resource facilities. But also we have another thing that is going on. We are centralizing the hospitals. You know, the Gotomis should be access to not above all this, you know, the digital transformation is being aligned with these documents. So wherever we have addressed in the PHC digital roadmap, of course, he has taken care of the priorities set within these documents. Before saying thank you, I want to repeat again. In order to have a successful implementation of a system, you need three things. You need people, you need process, you need IT. But people takes 7% for the system to be successful. Process is only 20%, and the IT is only 10%. So you could see, stop pushing your blame on IT. Try to change yourself. People should change if we need to have a very successful systems. Thank you very much. Thank you.
Thank you, Martanda, for a nice presentation. And now we welcome the last presentation for the morning, and that's by Emmanuel Johansen from Kepler Associates. And he's going to present on digital transformation for healthcare, auditing and risks. Emmanuel Johannes is a founder of Kepler Associates, a firm that deals with assurance, business advisory, risk management, and fraud examination. He's an expert in fraud examination, governance, risk management, and control. He has special interest on fighting fraud and digital transformation and international taxation. He's the chair of the African Federation of Institutes of Internal Auditors and a former member of Global Nomination Committee and the Institute Relation Committees, IRC, of IIA Inc. He's also a member of the Advisory Council of Association of Certified Fraud Examiners. He is also the chair of Audit Committee of the Ministry of Lands. So with that brief narration, let me welcome him to give us his presentation. You're welcome, Mr. Manuel.
Okay, so yes, thank you very much for the nice introduction. Can you confirm that you can hear me?
Yes.
Okay, so thank you very much. I think my presentation is coming at the very critical time. It's I think maybe people are already thinking of lunch at this time. So I would make it short. We have 15 minutes, so I will try to use 10 minutes if I can, and see how we can continue. So my duty is to talk about audit and risks. And since early morning, I've been listening to different speakers. They come with different topics. Some of them very technical, some of them they are very new to me. But I think I should just focus on one small particular area, audit and risks. Okay, so that's what I'm going to discuss in the next few minutes that I have. And I will try to speak in a layman language so that we can all understand each other. You know, so I will talk on about two things. The first is, why do we audit? And the second is, why do we need to manage risks? You know, because those are the two areas that I will speak about. And I would move straight to talk about auditing first. You know, so why are we auditing? What's the purpose of auditing? You know, so if we simplify, whether it is an external audit, whether it's an internal audit, or whether it's a system audit, because you've been talking about digital transformation, talking about systems. So, but systems are also being audited, you know. So whether it's systems audit, financial audit, performance audit, value for money, they all focus on two main things in my perspectives. First of all is to improve the systems and then increase the chance of success by focusing on the internal controls, risk management, and governance. So if we talk on about these three elements, risk management, internal control, and governance, I think I will come back to risk management later on because it's a separate topic. But I think governance has featured in many presentations that I've heard today. You know, when we talk about, you know, lack of appropriate framework, you know, for guiding some of these digital issues, for me, we are talking about the governance issues. So the question is, which one comes first? Do we need to have a legal framework? Do we need to have some guidance in place before we can proceed with other things? Or we start with what we have and then, you know, we can form the laws as we proceed along. So what we do in auditing is to help you achieve your objectives by focusing on those three things. So from an audit perspective is to give you the guidance. What do you need to do so that you can increase your chance of achieving your objective? So, but we're also focusing on helping you achieving that in time. I think time has been critical issue, a timely manner, and the most efficient and cost-effective way. So we don't say at the minimum possible cost, but we talk about the most efficient and cost-effective way. So that does not mean it should be the cheapest option, you know, but the option that is viable in terms of the time taken, the value delivered, you know, and balancing with the other factors as well. So those are the two main reasons why we are auditing. And while many people have different perspective of auditing and they see it as something that is probably interrupting what they are doing, and they're just doing it because they have to do it, you know. But if they had an option, they would cut it off. But if you go deep down and understand what is auditing, you realize that auditing is actually a good thing, as I've mentioned, as I've just mentioned here. So with the auditing, it helps you reach your goals quicker, but with the minimum also, you know, disruptions. Okay. So as we move to the next level, I will talk about risk management briefly, and I will also talk about it in a layman language. So ISO 31000 define risk as the effect of uncertainty on objectives. Okay, so all these discussions today, they talk about digital transformation, they talk about what you need to achieve 5 years from now, maybe 10 years from now, but the question is, there's a lot of uncertainties involved, because we don't know what will happen tomorrow, so we don't know if we'll still have, some of those funding or solutions, even a year down the line. So those uncertainties needs to be managed. So that process of managing those uncertainties to make sure that you are achieving your objectives is called risk management. So in other words, at the core of risk management is the decision making. So why are we managing risk? Because we want to make informed decisions. So that's the simplest answer in terms of why do we manage risks. So if we consider from perspective of all these presentations that have been done today, and I've heard about the strategy of the mainland Tanzania, the strategy from Zanzibar, so all of these, they involve uncertainties. They need decisions. They need deployment of resources. But in one of the presentations, which was delivered, I think, by the colleague from the mainland Tanzania, who was talking about the national strategy, health strategy, he was talking about lack of adequate resources. Again, the presentation from Zanzibar was talking about shortage of staff. So all of these, they're resources. Okay, so the key question is, how do we best deploy our resources when we have shortage? Yeah, so that takes back to the mathematics we used to do in high school or in O-level on linear programming. Given few resources, how would you achieve that solution? So that's all risk management is about. So both auditing and risk management, they are the necessary evils for you to be able to achieve all this future that you are trying to see. And from my own perspective, I consider three things. I've been listening to all these presentations. So I made my presentation this afternoon after listening to everything that has been presented. So my presentation is actually based on what you've been discussing and the things that have come to my mind. As top 3 risks, one of them is the issue of the cultural transformation for accountability. So because both risk management and auditing, they focus on accountability. So the first aspect is also based on my personal experience. I have worked with the higher learning institutions as an auditor. So I have worked with professors, I have worked with doctors, engineers. But one thing that I've learned, sometimes they tend to think, what they do in science, whether it's a scientific research, whether they're trying to find an engineering solution, is the most important thing at that particular institutions. So in other words, they tend to disregard sometimes the controls, they tend to disregard some of the rules, they tend to disregard governance, because they feel like, what we are focusing is results. We just need to achieve these results, so it doesn't matter how we get there, So one thing that I think, the message that I want to pass through this forum, and with a lot of due respect to many professors and doctors and scientists, is, and I've worked with them who knows and follow the rules, so I'm not saying all of them, they're behaving in the same way, but I want to say the first thing that we have to put in from the beginning at the mindset of the digital transformation, in the health sector, is that cultural transformation, to accept accountability. We have resources that we need to utilize to achieve the results. So we need to be accountable. And part of our accountability means we have to be audited. We have to produce risk report. We have to show the indicators, and we have to prepare plans on how are we mitigating or are we managing those indicators to make sure that we are attaining the end results, which is intended to be achieved. But I've also identified some technology risks. and I will talk about technology risk shortly. And lastly, I will talk about sustainability as one of the key risks as well. Yeah. So I've spoken about the cultural transformation. In one presentation which was done today, somebody was talking about duplication of information. When you have too many systems, and I've seen some organizations where they develop 3 or 4 systems, but half of the things which is done by system B, they are actually part of system A. And also the other 20% is part of system D, and etc. So it comes to the question of how do we optimize the resources? How do we avoid the duplication to make sure that we use the resources efficiently? Or if there's a possibility of expanding some of the functionality in some of the systems and making sure that we can add some additional things instead of deploying completely new expensive solution, how do we do that? How do we achieve that? So all of these are coming as part of the benefits of risk management and what audit can do about, because we come to you and we advise you. We have auditors who have IT background. We have auditors who are computer engineering. We have auditors who are medical doctors as well. So when we come, we team up, we put all the minds together and see what's the best solution that we can offer. But when you talk about value for money, when you talk about these systems, digital transformations, some of these systems, you're talking about millions of dollars, but again, statistically, most of the projects, most of IT projects, information technology, actually, they don't get to the end. They end somewhere in the middle, while you have already spent millions of money and time of people. So how do we increase the chance of that success? So how are we going to be held accountable? How do we follow the rules? Do we have the right governance structure and follow principles instead of rules? Yeah, because you may have rules, but following rules may not mean that you are doing the right thing all the time. So we also have to understand the principle behind why those rules were laid down, And so sometimes when auditors are coming to you, they tend to remind you some of those principles, why there was this guideline, why there was this, But again, we have spoken about the issue of resources, which is critical. So in the case where resources are not adequate, and I have not seen anywhere where resources are enough, we talk about how best we can optimize, so auditing and risk management can help you achieving that. Yeah. But then the issue of technology, which is it's part of what we're discussing today. We're discussing about digital transformation. And a lot of people have been talking about AI, artificial intelligence, robotics, etc. So while I'm not an expert in that area, but I think with any technology, you need to have a governance framework, which from the discussion that I had today, it's not an area which has a clear cut, that we have a clear framework for delivering our transformation. So it's something worth considering, because if you don't have the right governance framework, the chances of you not achieving your objectives are decreasing. So the governance framework improves the chance of your success by defining what should be done and responsibility as well. So I think that's very important. But second, while we are developing all these solutions, while we are looking forward to all this digital transformation, we should also think about things which may come with the technology. And one of the things which has hit the healthcare industry, in the last 2 months, I've had 2 major cases, but generally, the healthcare industry statistically is the one that is attacked most by the cyber threats. So in other words, cyber security should be one of the key concerns on the designing of these digital health systems, because they protect key information for patients and clients as well. There's a recent case in Australia. I think I was reading an article, I think about 2 weeks ago, where I think there was the healthcare system in Australia somewhere, there was a ransomware. And so part of the information that have been captured are the critical patient's information. and they are sensitive data by any means. So there was an expert who was advising the people responsible to pay the money so that they recover those data and to prevent the leakage, to the public, because it's so critical. So the government rule is we don't negotiate with the criminals, we don't pay for ransomware. But in that case, a high level official, a cyber security specialist from the government, was saying we have to pay, because if we lose this information, if they leak this information, it will be a disaster, So if you talk about, for example, recently in US, I think the fourth largest healthcare provider has been hit by cyber. Is it a ransomware or something like that? And so there's been a dispatch of ambulances to areas where they're not supposed to go. Patients have been given medicine which they have not been prescribed. So it's been a total chaos because everything is in the computer, everything is being digitized. So I don't know if they have solved that problem already, because that's a recent case. But what I want to remind you, as you think about all these things, you should also think about the risks that are coming with it. So I believe I have exhausted my time. My time is not very friendly. But I would also remind you, the more we are interconnected, the higher the risk. So it's not only about collecting the patient's data and information, the doctor's data and information, but those connectivity connect also to our bank accounts. They connect to our kids, network of whether they're using computers, iPad, etc. So this interconnectivity is also a very high risk, which means that we should spend the necessary amount of resources on security. So it's not all about scalability, just expanding and giving the right healthcare solutions. It's also about the protection. So there should be the right level between giving a solution and what should be protected. And also the other thing is, and I'm gonna, the chair, if you allow me, I'm gonna wind up in 2 minutes, if you allow me just to highlight these few points, which came from the discussions. Today, you've been talking about AI. AI was the most famous word that I've heard, today. So, and then in my research, it tells me, AI is used for surgery as well, because there's robotic surgery assistants where they use artificial intelligence. Yeah, but also in some places they are doing early screening to diagnose diseases such as cancer. They are using the technology, but also there are some medical research. I've seen one firm in England, in UK, that is using AI to match, I think, genetic information of different patients, for discovering drugs, or so it's some sort of researches. So the question is, with all these things that AI can do and technology can do, have we considered the risk that the technology may malfunction, either by human error or by the interference of a third party, such as hackers, etc. So the possibilities are really scary. Imagine if you misdiagnose a patient because somebody has tampered with the system because there's no right protection, or your research results have been tempered in such a way that you are arriving at long conclusions and believing that you have the right results, but then the systems has been interfered. So ladies and gentlemen, I think it's very critical. It's very critical to consider all those things, as part of the risks when you are designing or when you are considering the digital transformation. In the healthcare industry. And finally, my last comment is on the sustainability. From the tone that I've heard from different speakers today, was like, we have donors here. Donors can hear this, donors can hear that. So my question is, are we designing things with the sustainability in mind? What if the donors don't provide you with adequate resources? Would you be able to complete those projects? Yeah, so for me, I think sustainability is one of the top risks as well that you should consider all the time. So it's high time, also, as much as we would like to work with the development partners, but it's high time also for the government and those who are involved in decision making to consider also investing in your own researches, set aside some funds, just for continuity, So ladies and gentlemen, because of the time, I would like to stop here, but thank you very much. Asante.
Thank you, Mr. Emmanuel. Thank you. You have used 20 minutes instead of 10 that you promised, but I'm sure everybody was happy because the presentation was interesting. I, for one, thought we always do audit on money, but today I learned we do audit even on risks and other things that I've learned from you. Thank you. Now I welcome questions or comments for the presentations that have been made in this afternoon. And if I should remind you, we had presentation on the digital health strategy for the mainland. We had digital health strategy for Zanzibar. We had primary healthcare digital transformation from the PO route, and we have this final presentation on auditing and risks. So I welcome 5 comments and questions. I'm going to limit the time we are going to discuss because I'm told lunch is ready. So 5 questions, and then they will respond, and we shall see whether we continue postponing lunch. Welcome. Who goes first? Please come forward. I think Sukums is the first.
Thank you very much, Mr. Emmanuel Johannes. I declare that Emmanuel is my classmate. He is an A guy, so you can understand the materials he has provided. Thank you very much. My question is on how do we, unfortunately I wasn't going out and in, how do you effectively integrate audit risk in the software development lifecycle? You did your undergraduate on electronics, and so you had some issues that you studied on analysis. How do we integrate this? And the also other thing is capacity of ICT officers or professionals in really integrating audit and risk, because it's not subject that is really taught at the universities or colleges. Thank you.
Thank you. Second question. Welcome, please. Remember, it's question for all the 4 presenters.
Okay. Thank you very much for the view of auditing with the digital technologies that we use. It's very impressive that we have an audit system, but then I need to know if one of the key things you face is the development of these digital technologies. I always done without the users, and we are currently having many drawbacks in using those technologies simply because we're not involved in developing them. So how does that feature with the auditing? Thank you.
Thank you. Please welcome.
Right. Do you hear me? I have 2 questions. One question is, in many of these presentations, we have seen the resistance from people that actually want to use it. And my question to the speakers and then people who gather there is, how do we change that? How do we make resistance something that people actually want? That they crave, they really don't have this new transformation. That's my first question. It's a very difficult one. And the other is, I haven't seen a single calculation of the value and the benefit in money and the time for return on investment. I would like to say, could you translate your presentation into money? into return on investment, into what we complete, what we get out, is that variable decide upon. We can continue, if we start, we stop. Those are what we do. Thank you.
I have two more questions before I welcome the presenters to respond. Yes?
Hello. Thank you all presenters for the nice presentation. I have only one question regarding to the guys from the government. We've done much efforts in developing digital solutions and the documents. So the issue is, how do we integrate the private hospitals, for example, in Dar es Salaam, like in Rwanda or other countries, their digital systems to the government platform. For example, the Kamisemi, they've said they go to Muungano Gateway, MOH, they go to their gateway. How LRH, THC, the private owned facilities, they come to the government as a whole. As we know, also they are using government tools like Mitua. How about the digital systems? Again. But when we go to the outside, now is the second issue. When we go to the outside, when will we go outside? Meaning that outside for university coverage, then to the citizen-centered design. Well, now we're facing some challenges, but when we go outside, how are we preparing ourselves to meet the citizen? If there is a resistance to the professionals, me and you, how about the citizen? How do we prepare for that? Thank you.
Thank you. And the last one from me, that to the Minister of Health, you have machinery for looking at fragmentation so that all systems that are incoming are checked before they are allowed in. Yet we still have lots of fragmentation. We have BIS, we have ELMIS, we have DHIS2. They all overlap in one area or another. Did these pass through the machinery? Thank you, and let me, since that one was myself, let me allow the fifth question.
Thank you very much, the co-presenters. Mine is on the, how are we preparing the health professionals at the universities? The dentists, the medical doctors, the nurses, to become the champions into the implementation of the whatever system that we're making now. Because so far it's just a single subject and on the basic science where people are taught on the ICT skills. But I don't think it's enough for them to move on, use it, and maybe make innovation out of it if they come into the really system of application and become the doctors in the system.
Thank you, and let me welcome Mr. Emmanuel, because he has the most of it, to respond before I welcome officials from the ministry.
Okay, thank you very much. I think there was a lot of difficult questions coming my way. There's one that one speaker that I didn't hear properly because I think that microphone is not audible enough, but I will try to answer, to start with the first two questions which came. How do we integrate audits and risks in the design? So I would say that's a very good question, but also it's a very, it may have a very long answer. But to begin with, I think in the design of the systems, there should be a proper methodology that has been used, because that's part of risk management. Which methodology are you using? Okay, so is your system, so that's the system development life cycle. So which approach are you using? So we expect that there would be the right governance structure in the designing of the systems, because system is like, development is like any other projects. So there should be proper systems of, the designer, the tester, the reviewers, etc. So I think that's part of the critical aspect that has to be considered. Practically, for example, not in healthcare system, but I know systems that have been designed here in Tanzania with the government, but then the same people who have designed, they have retained control of most of the functionality, and then the users, they know very little, and they have very little input and control in terms of who should access what, because the people who have designed at the back end, they have retained most of those things. So that's not very good in terms of the governance and also the controls. Yeah. Okay. So that's one aspect. So in the healthcare, it's the same thing. So I believe there should be proper methodology for designing, but also when you are designing systems, there should be proper controls. So let's say you're using an AI-based solution. So the question would be, if there's an error, which has been made, by the system, is there a mechanism for detecting it and correcting it if possible? So that should be integrated in the design, which means the system also has a mechanism for doing the self, review and correction. It gives somebody first a room to make any amendment in that one. But also there's issues like audit logs, some logs in the systems whereby the system should be designed in such a way that if I want to check some of the functionalities or some of the things are working okay, I can go somewhere on the audit logs and I can click and get most of the activities that have been done in the system by who, etc. what time. So if there's any change, somebody wants to override some things from the systems, have we designed it that it has to follow the right approvals, in the process. So I would say all those things should be taken into account. Issues of technology, do we design with the scalability? Because if we do that, if we design in such a way, if there's any shortfall or any challenges later on, we can come back, and rectify some of those things. What technology are we using? Are we using an open source, or is it off the shelf? So all of those considerations should come in the beginning from the risk assessment. So there are two levels of risk assessment here, in the designing phase, but also in the implementation phase. But also once the system was concluded, there should be the post-implementation phase before you can test the system with live human beings. The test should be done in a smaller scale, and then the results validated. And if there's any problem, it should be rectified. So with all that in mind, still you will need human beings to come and do the audit. So there will be self-checks from the system, but also the human beings can come later on and test the results of the system. So I would like to end up at that point. If there's anything that I have not addressed, Mr. Moderator, you can remind me, and I can take it. Thank you.
Yeah, there was this question of value for money with regards to the audits and the whole issue about whether, the benefits of, if I'm really asking correctly, the benefits that one gets from the risk analysis and auditing, is there a calculation for that in terms of costs and return for money in the development of those systems? I wonder whether I've made myself clear and whether I've really asked it the way it would have been asked by the person.
It's very close.
Thank you.
I think it's guided toward all the people out there.
So if I get it right, so the question is, what if we don't need auditing? so what value are we getting out of audit? Is that the question? Is there value for money for having audit? I mean, in all these things. So if I have understood it correct, I would say I don't have numbers here. I don't have statistics, but the failures that are coming when you have hit by any of those ransomware, cyber attacks, whether you have designed a system and you don't end up achieving the results that you wanted to achieve, the cost of that, I think for me, can be significant, can be very significant. And I don't know, but if I have to look at the other side as well, people wouldn't be doing, auditing if there was no value for it. I don't have data, but I know, for example, let's look, even the government that is highly developed, like, for example, United States, they invest a lot of money in making sure that they design systems with auditing in consideration. They develop laws, they develop guidelines. But the reason, people do that is because they have done some researches. I don't have data here, I don't have numbers here, but I really feel auditing is important. So what if the donor has put $5 million to develop a system and no one checks about it? There's no accountability required, just develop the system. So how do we know that $5 million has been spent, how it was supposed to be spent? How do we know that the system that has been designed is what was supposed to, to be developed? Because there are two parameters here. It's not all about the money, but did you get what you wanted? So auditing is looking at many other aspects. So for me, I have seen areas where the system was supposed to deliver A, B, and C, and because there's no proper checks, no proper audit, no review, the system is only delivering C, and people are happy. They think that they have a system in place. So if I have to sum up, I would say I can't give you the data, but I believe it's quite essential to have auditing in place. Thank you.
Thank you, Johannes, and we welcome Barume from Ministry of Health to tell us about resistance, procedure, involvement of dentists and doctors, the private hospital issue. I think that's very easy.
Niko na profesa, pana profesa ameniambia ni very easy, kwa sitaki kumangusha. So la kwanza, resistance to change. It starts from ideation. You should involve people, should involve end users from ideation. Before the system is developed, involve them on the ideation phase. Show them the problem, tell them what should be the solution. This end user will tell you the solutions. Then you document the solutions. You end up define the solutions to the requirement. And once you introduce this, you develop the solutions, the end user will see that you have created the solution which they need. And basically they support you. The second phase is to make sure that you involve the top administration to effectively supervise the implementation of the solutions. And once they pose these provisions, the end user will follow. Another solution is to introduce mentorship on their daily week. You make sure that you mentor them to their daily week. Another solution is to make sure that you introduce the solution which act like job aids, yani inawasaidia katika kazi zao za kila siku. Na sio hiyo additional way kwenye kazi zao za kila siku. Unaona kama unaongezea mzigo. Na kama ni job aid, if it is a job aid to their daily work, they see that you actually help them on their daily work to do their daily work. That's my answer. Another question which we do have is about LMIS, DHS2, and VIMS.
LMIS.
Yeah, LMIS, DHS2,
supply
and VIMS.
chain, and VIMS is supply chain.
Yeah. So the question is, are these not duplications? Where was the machine at the EST committee? With this question, let me welcome Mr. Watan Desanjo, My senior officer, the Minister of Health, to help me with this question. What are you welcome? He is my boss, actually.
Then you can finish with the dentist.
He also finished it.
Ah, okay.
What are you welcome?
Dentists and doctors, what extent are they involved? Or we just teach them as, I don't know, simple ICT and expect they will know the rest.
Yeah, what are you welcome? I think, let me finish with one thing. For instance, with mobile phones, every year, every 2 years, iPhone release iPhones, eh? But we don't get training about how to use iPhones, but we manage them the way, yeah? What a welcome.
I thank you, Prof. As my colleague said, my name is Walter Desanjo and I'm coming from the ministry. Professor, regarding to your questions of the fragmentation, fragmented systems, and some of them it's like silos. Let me start to say one thing. You know, in ICT initiatives started way back before even this guiding documents, before these strategies, architecture and others. So what we did so far, yes, there are some, but if you go back, I remember there was a time we did assessment and we came up with almost 120 systems. And most of them, they were fragmented, yes, but for the time being, we are talking about less than 30 systems. And the fragment, to have many systems, was many of them, some of them which are fragmented, it also depends with the collecting tools, the collection tool that they are using to collect data from, facilities. Some of them, yes, they are not even integrated. So once the tools are not integrated, it is easy now for the system to be not integrated. And for the system that you said, for example, logistics system, ELMIS, and the HIS, and the VIMS and others, of course, those are the big systems of which they're supposed to be there. For example, ELMIS, the logistics system, and according for the machinery that is overseen, for example, right now you cannot start any logistics system because it's already there. You cannot come up with a system that is going to aggregate data, of which we have got the HIS, now we are using as data warehouse. And all these big systems, they're integrated with the DHIS, and the good thing that they're integrated via mediator. And all of them, they are keying data to the DHIS. So for few that we have, we are still working on them. And you know what, to take up the system is not like switch off the light. You have to go slow. There are many data in those systems, investments. So we have to look that we cannot disturb the business process, and we have to make sure we come up with the right data. We are not going to miss anybody in the process. And for the last one, that how do we at least make sure that all these workers that they are using our system, they're involved? Yes, for example, we advise, and for us, we cannot put, let's say, EMR in the hospital without involving users, without involving all departments. They're supposed to be used, they're supposed to be engaged from the beginning all the way to end, from user requirement, specification, all the way to UAT and that. So the thing is, now what we are doing is to make sure we engage them, we engage all users, all stakeholders from the beginning. And another thing, we need to create awareness that systems, they're not coming to take their jobs, rather they are going to help them. Once you show that if you are using system, it's a matter of clicking, you get your result, you get your report as you need it, and they see that is going to, like to make them to be aware of the system and to like system. But otherwise, if you are not engaging all stakeholders, then definitely it's going to be somehow hard to use this system. So we are trying to engage them from the beginning, and even these machinery, these machinery that we are using to oversee development and the implementation of these systems, of course, they're making sure that all stakeholders, they're engaged before introducing any system. I think those are my answers. If there's more, I can ask you. Thank you very much.
Maybe private sector.
Private-
How is it involved in the systems?
Oh, private sectors. If I remember his questions,
Private hospitals, private clinics.
yes, what we did is, the government, we already gave out the guidelines of developing system, for example, Yamaras. So we encourage private sectors to use such or those documents. And by the way, in this machinery, yes, steering committee, we have got members from private sectors. We have got members from FOB, first-based organizations. So they know what the government so far needs. And of course, we are not going to take all private, let's say, hospitals and to make sure they are linked to our system, let's say via him, whatever. They can link it to DHIS because at least all of these, for example, Yamaras, any product is DHIS data. So some of them, they are already integrated, but before integrating, we have to make sure they meet all of the standards, security things, and at least to have the proper data and as we expected. Thank you.
Thank you. I wonder whether you want to add.
Yeah.
Okay, you may come.
Yes, thank you, please think what first, I would like to add something on the first question about the audit and the risks. Nowadays, when you want to develop any system, of course, we are talking about the SDLC, System Development Life Cycle. We add an S on it. We call it Secure System Development Life Cycle. So you engage the security guy, the system security guy from the beginning. And the risk could be identified during the planning phase. Because during the planning phase, we have some documents that we prepare. As a government entity, you have to adhere with the, you have to align with the figure. So before starting any development, you have to make sure you submit the project charter to the GISP portal, the government information system portal. It's where they go and they do all the other things, they do review all the documents. So at first, the project charter should have risks and the mitigations. Then when you go to the analysis phase, during the requirement gathering phase, we know that document holds the SRS document, system requirement specification, and two parts. It has the functional requirement parts, where it speaks about what the system will do. But also, it has the non-functional requirements, where it speaks how the system will behave or how the system will operate. So there, you could also include the security part of it. But nowadays, the security document is being developed independently. And during the analysis phase, there is a certain madam here was saying that they have never been involved during the development of the system. I think that's a big lie. Because how do you come out with the requirements if you're not utilizing the human factor? And how are you going to test the system that it fits the human department? Because you have the UAT part, the user acceptance test. So you could see that people have been involved, but they were never involved during coding, but during design, during analysis, during the user acceptance testing, then you will be involved. And for us as a government right now, every step that you go, you have to get an approval first
from here. You have to get from here. Regarding the duplication, of course, regarding the private and the public, for example, Gotom is right now is being used by 18 private-based organizations. They are using Gotom. But the duplication and efforts we have here. So before commencing any projects, you have to make sure that you commit your idea at the state government, the GS2 portal, and then they look at it in review and see if there is a certain organization that is implementing the same, has implemented the same idea. They will never give you a go ahead to implement your institution. The value for money. Where is speaking the value for money for the systems? Right?
Yeah, among other things.
Yes, we put down the systems. For example, for us for the EMR, we don't care too much about the money spent, but we care about the service delivered to our clients. But if you want to speak about the cash, we have some facilities that they were earning almost $1 million a week, but right now they're making $10 million from using the systems. But for us, we don't talk, that's the peanuts when speaking about these. We care about the continuum of care, not the value of money that is being generated. Thank you very much.
Thank you. That brings us to the end of the session. The dentist doctor wasn't responded to, but I think the answer is you take initiative. If you are producing students, make sure that they know what is happening in the field. They have told us what is happening in the field, and our students have to go to the field. So they have to learn what is in the field. With that said, let's give a round of applause to all the presenters. And to all those who asked questions. Another. Thank you, and I'm told lunch is ready for you.
Administration.
Good afternoon. Good afternoon. Please kindly register if you haven't registered yet. The registration table is outside.
Good afternoon again. Let me do this.
Plus.
Wageni wako wanaenda nao kule.
Wageni basi. Wageni wako mchuto. Wabebe wakuja kule.
Kuna kitu gani?
Nilikuwa niko hapa sisi wiki hii kwa hiyo tuna event tunaziorganize this event tumetoka break ya lunch ndo nimepiga. Sasa Dr. kama nilikuwa na present naanzaje virtual presentation naenda ndio maana nikakwambia
hiyo kwingine ni hasara ya keynote. Huyo PhD ndio wale wa nataka nichukue kwenye flash in case mtu anaweza kaja hapo kwa baadaye tukue chakula atafuta vitu.
Ngoja nitaingia nitawavuta wapi.
Siku.
Ndio.
Hiyo hapa ndio ya mwanzo ile.
Hii ndio anaifuata. Inafuata. Mwingine bado hajapata. Wale wengine watatu ndio huyo hapa. Kuna mwingine nani atakuwa naye ni online nadhani mkombo. Alafu huyu hapa naenda. Utatenda.
Bado nani tutamaliza.
Utawasubiria. After lunch now. Wawili.
Watatu baada ya lunch.
Aina ambaye ameshaweka uji.
Tamarima mmoja.
Nataka niweke ile tangazo. Tulikuwa tunanani ngoja naweka ile tangazo. Tayari kashaandika comment nani Dr. Felix.
Wote ni nzima hapa.
That's my Niambie shida ni nini? Matini kwangu kwa naangalia mfumo na kulipa vizuri na hiyo.
Hello, is this on? Hello. Yes, good afternoon. So we are starting our first session this afternoon. I hope you have enjoyed your lunch. For those who are online, I'm not sure whether you get your lunch virtually. We send them via Zoom. So we are going to have two presentations, three, but one presenter or speaker is missing. He will be presenting tomorrow. So we'll have presentation from Dr. Adija Malima and Martin from Denmark. Yes, that one may be cool. So please load the second presentation.
Nachukua hiyo nani kwa usifuti hizi nikafikia unazifuta maana kama unaweza kufuta sasa ndio sasa huyo alipresent nani kwenye manager hajatoa mzato
So good afternoon once again. So our first speaker will be Dr. Adija Malima. As you can see, she has two backgrounds or profession. She's a nurse, but also an epidemiologist, and she's the chair of National Health Research Ethics Committee. She has been also the coordinator of e-health at the Tanzania Commission for Science and Technology. So e-health, digital health has been her home. She's currently conducting a study on the use of digital technologies to enhance children with disabilities. I think she can explain better the title. So I have a great honor. She's a lecturer at School of Nursing here at Mohat. She's a good friend of mine. We once attended an e-learning training at Oxford University, I think like 5 or 6 years ago. So Dr. Malima, karibu.
Asante sana. Good afternoon, everyone.
Good afternoon.
I was asked to talk about ethical conduct in digital health research and innovations in healthcare. I have a short outline, which will start with the foundation of ethics in human research, technological transformation and its effect in healthcare, and then opportunities and challenges in health research and digital transformation. And we'll talk a little bit about the future. In principle, the foundation of ethics in health research
It sets values, it's a set of values, norms, and institutional regulations that help to constitute and regulate scientific activities in a country. It balances research and demands versus participants' rights. And this is based on the Nuremberg Code of 1949 and the Declaration of Helsinki of 1964, which had set these standards, and I think they're globally adapted. And for these principles, we have three main ethical principles that govern health research. First is the principle of beneficence. Second is the principle of respect for human dignity. And the third is the principles of justice. Thus, when we identify and safeguard ethics in all technologically led health research or health services from developers, users' perspective in social care and healthcare is very important. Such services should not prejudice the quality of services or the social interaction which is required in care. So these principles remain. Whether digital development goes to the roof or goes anywhere, these are the key principles that we all have to adhere. But however, with that being said, we come into digital development, which has transformed healthcare in so many ways. There are so many gadgets you can see here, but what does that mean? We know that digital transformation in health research, in healthcare, has introduced a disruptive technologies with regulatory, management, and conduct of health research systems across. It has actually disrupted in the sense that when we say disruption, this is when a change upsets the current systems to such a point that the incumbents operating in that system cannot adapt to that change. You heard the previous speakers were saying about we're not managing to use the digital technologies they've provided for us because we've not managed to actually come into terms for some of us. And some of us are so far ahead to the point that we leave others before they can catch up. So we're not moving together. So this has made research management much easier and at the same time much more complicated. Why am I saying that? We know that digital transformation, for example, in healthcare, it has actually brought in a value-based care. We're now not focusing on just a multitude of things, but we're focused on the value of the service we provide. It's also meant to cut costs. And digital transformation in healthcare has also reinvented electronic health records. We're now getting away with doing all these files that you see in the, what do you call them, masijala, so we want to do away with those things. And then we also have an opportunity for data analytics, which we're not using very much. So we hear. So when we look at a brief comparative analysis in the internet penetration, because that's what is introduces the digital technologies. We know that in sub-Saharan Africa, it's only 45% of the population use the internet. And once you use the internet, then you have a door to the digital gadgets that or facilities that you can use. And when you compare with 83% in developed countries such as North America, you know that this is very small, but overall, globally, it accounts to 67%. In the Nordic countries, for example, in Finland, 75% of the people are aged 65 to 74 years, and that was last year. And 37% of those aged 75 to 89 years use the internet and e-health. So when you look into the comparative advantage or disadvantage, for us, it's the young people and everyone else is 45%. So if you bring in e-health, not everyone can use this. Oh, okay. Not everyone can use the e-health facility, and we've not very much advanced into that right now. So looking at this, you know that we have a long stride to take before we can actually get the benefits of digital development in healthcare. I think one of the challenges in health research and healthcare is that the digital development industry has actually brought in about 8 new digital players in the healthcare industry. We used to think of just the lab technicians, the doctors, the nurses, and the first aiders, but now it's more people who are involved. They are not directly giving healthcare, but they do play a key role. For example, we have this virtual, the AR and VR providers. You know, they can bring all the imaging within where you are. We have the market intermediaries, madalali, still. And then you have the cloud service provider who is also housing all these big datas. And then you have the data technology providers, the artificial intelligence developers. Then you have information platforms. You have blockchain-based PHR, remote care technology providers, intelligent data analysis providers. And then at the center of it, you have the healthcare professions. You have the doctor, the nurses, the lab tech, and everyone else. So if you have such a wide array of key players in health, what does that mean? It means we'll all be scrambling to get recognition, scrambling to affirm our positions, scrambling to make sure that the patient gets all the benefits. And I'm not sure that is happening right now. So our key ethical issues in the digitalized world is the first one. I've lumped them into two, but they speak a lot for themselves. The first is personal data collected in healthcare systems is subject to human rights legislation, and therefore it needs to be protected. Now, when you have very detailed information about a person, you actually compromise confidentiality, because if you have all those players and each one contributes to something towards the generation of all the storage of that data, it means there's actually no privacy. You'll have more than one point of control. The beneficence and malfeasance is actually compromised as well. And there are times when there's no justice in the service provision when you have digitalized everything and you compromise trust. The issue of data protection. If you upload all the data somewhere and there's a cloud service, you're not even in control. How can you guarantee me that my information is not going to be available somewhere? And then, so the property rights is also compromised. And then you remember those 8 key players I talked about in the previous slide. It compromises dignity of these individuals. And then there's also fairness and proportionality. And of course, there's also benefit sharing. For the person who has actually developed an app, and we as patients are using it, or we validate it. We do research to validate the app use or any technology. When we validate it, it goes into the market. That person accrues so many royalties. What about me? I am the patient. I'm the one who validated the utility of your app. What am I getting out of this? So there's also a question of benefit sharing, and that is also an aspect to it is really challenging, and we've not made a point to make sure that that gets accommodated. And the second issue as an ethical concern is the research from the user's perspective is fragmented. I think in Tanzania, there are very few, not many health research actually focusing on digital technologies. If at all we're using those, it's when we collect data using iPads and stuff, and the data goes straight up into a server somewhere. It's within reach. It's not, I mean, it's not even within reach. You might have an iPad, but it all depends if you can access the database. So it all depends on what you have agreed with the partners you've been working in. So who are those that perspectives are fragmented? We have the illiterate people, not illiterate in the sense of health literacy, but they cannot even read and write, which means even if you bring in a service that can use a mobile phone, these people are out of context. They cannot be reached. Issue of beneficiency is actually compromised. And then you also have those with low health literacy. You might have a mobile phone, you might have been accessing, or you have access to certain information about your health, but as long as you're not, maybe it's in English, you cannot read English, you cannot understand, you are out of scope. And if at all, it is used for any other reasons. So for example, right now we know that when you have, you're feeling certain symptoms, it's so easy to go online. and read. I know we have that app. We have that app in H1Nini. Oh, I forgot. I see it every day. That app which you can feel your symptoms, and then it gives you a Tanzanian app. It gives you, maybe you're suffering from something. Someone should know it. Ada, yes. Ada. Oh, I see it every day and I look at it and I use it and then I forgot. Okay. So for that type of service, when you're using Kitochi, you're out of touch. Okay. So the user interface is also very important, and we have not done enough research to access that type of information. And of course, for those who are underserved, now we're talking of people who do not have electrical power. So when you bring in digital health, what do you really mean? When you bring in e-health? So this is an area where Tanzania needs to focus on research so that we actually know what the user needs and what the user would be able to adapt to make sure they get a healthier lifestyles. So in brief, I've just put 2 columns. When we talk about digital health research or how the digitalized world has affected our research, it's mainly in terms of privacy, beneficence and malfeasance, loss of control of data. When you collect data using digital platforms, it just goes somewhere. So researchers need to be aware of that. They need to, negotiate better. Benefit sharing after digital trials in technology-driven health research is absolutely not even existing. So I think one of the challenges is it compromises. If you use a certain population to validate an app or a digital technology, I think in all fairness, the people who have been involved, or the society that has validated, whatever it is being validated, should have some benefit sharing. Not too much, but I think researchers now need to up themselves, up in their game so they can negotiate better deals when they collaborate. And of course, the 5th one, I've already mentioned it's about trust. When you have all my information, all my sensitive information, it doesn't help. In the healthcare, there's one thing, fear of acceptance and lack of control of technology. You have a certain hospital X, they never had health management information system. And here comes a person who has developed that information system. They certainly wouldn't have the right to edit or adapt some of the programs unless they're being given the go ahead. And that will never happen unless you negotiate. So when you are using someone's system, you load in all your data, you need to have access so that you can use it or you can change it and you adapt it, see that it works for you. If you don't do that, you have actually no control, and sometimes you cannot even make use of the data. The second challenge in healthcare is the digital mindset and workplace adaptation. I think the previous speakers spoke so well about this, that we need to change our mindset. And unfortunately, we don't see many of the physicians in here. We don't see many of the nurses who would have to adapt to these technologies and make those changes. So our mindset has to change. It's one of the challenges in healthcare. Privacy, again, is a repetition. And then, of course, there are costs. All these systems, they're not cheap and they don't come in when you just sit and then it comes. No, people have to work, people have to think, people have to code, people have to design. So there are certain costs associated with it. But then I believe the management can actually do a better job at looking at the cost. And Josta managed to ask a very good question, okay? What is the return investment on this? And I think this is very important. You cannot just go and get into programs without knowing how much it costs, because that makes sense. Is it cost effective? Is there a benefit apart from what, I'll be in the trend with the digital technology, which doesn't give us any return value? So that is one of the areas I think we are facing as a challenge, and we need to up our game. Data security again, but the other one, the 7th challenge, unused data. This is so common. You know, right now when I'm thinking, why should I write a huge proposal? I would stay up all night when I can actually write a letter to the Minister of Health and ask the data that has never been analyzed. We're taking samples, we're checking biopsies, we're doing all these analyses, but we need to analyze those. So students would have abundance of data. You don't even have to look for research money. You just need to know how to analyze. And that is a resource we're sitting on. And of course, the 8th one is the limited technology savvy personnel. I will never get into the bottom of this, but I think most of us, I don't know, when I look into this room, I think maybe I'm the oldest in here. Maybe in Yosta. The rest are young people. So then when I look into my colleagues, we still have like maybe 5, maybe 6, or maybe 10 years to work if you do not get into the digital technology and upgrade yourself. How are you going to cope? You know, there's that failure to thrive, right? So failure to thrive also comes with digital technologies. You have to up your game to remain a productive person. So I think I was thinking I was going to talk to all the persons today, but it's unfortunate. It's always the same faces, all the young people. So keep it up, young people. But I just want to underscore the significant benefits of digital transformation in healthcare. Enhanced patient engagement, if it works very okay. If you have all the people using e-health, I mean, what else would you need? No one will be running around. You can cover a lot of people in one hour. Efficient healthcare analysis, which you also need to make use of. Improved care to patients, timely assistance, if at all the respondents actually pick up their phones. Eliminate human errors. If you have artificial intelligence operating, you've trained it well. It now does, they have used artificial intelligence for cancer diagnosis. How many slides per minute? So that is wonderful. Access to real-time healthcare information. When you have any symptoms, you need to Google up, you need to look into the credible websites for information that can guide you. And then data privacy and security can also be guaranteed if you use the principles right. Remote patient monitoring, that is also very important, especially for a country like Tanzania with 61 million, but we have very few referral hospitals, which are also not manned with adequate human personnel. They also have to struggle. So if we were using this, and then it could have been really important for us to make these changes. Preventive care, we've forgotten about preventive care, but one of the greatest advantages with digital transformation in healthcare is, you know, sending out this preventive information. I know there are systems where they send SMS messages to remind people to come to the clinic for those who are diseased, but I think if we use this for preventive purposes, we're going to be better. Right. This is my last but one slide. How can we change or adapt to pick up the low-hanging fruits? You know, people have been busy in the world. There are people who have been so fast, they're so advanced into thinking and developing new things. We just need to tap. We don't have to struggle like they did, but we need to adapt and pick these fruits because they're already there. Unaona embe limeiva kabisa. Yani unachotakiwa kufanya hivi kulinyanyua. You have less work compared to mti ambao umeanza kutengeneza lile embe, miezi and all that. And I don't think I'm the best person to give this advice. This is for us to discuss, and this is for us to come with resolutions. Last, I thank you very much for lending me your ears. Thank you.
Thank you very much, Can you sit there? So that you, you said there so that Martin finishes his presentation. So that was Dr. Hadija Malima. And lady who has a health profession to say. She is a multi-disciplinary. Yes, epidemiology, ethics, and She's a partner, sure, she will provide a lot of support to our youngsters. So may I now call Martin Griffenbeck, I hope I got it, from World Diabetes Foundation. Martin has 8 years of experience as Senior Program Manager on Digital Health Solution at World Diabetes Foundation, responsible for what is called Diabetes Compass. He will tell us what Diabetes Compass is, which is implemented in Tanzania. He was previously digital product management of biotechnology sector. He obtained his master's in organizational innovation and entrepreneurship and bachelor's in international business and politics from Copenhagen Business School. Welcome, Martin.
Thank you. So there's no need to introduce myself again, but I'm here to tell you a bit about the Diabetes Compass, digital health initiative that we've been working on for the past year in Tanzania and a few other countries. But before I do that, I'll tell you a quick 2 sentences about what the WDF, World Diabetes Function, works as. We work through partnerships and are now one of the leading funders in diabetes-related healthcare interventions in low and middle-income countries. We work in around 100 countries, from grassroots all the way up to national-scale projects, as we have here in Tanzania. And I believe we're working in around 120 we have around 120 active projects at the moment. But I'm here to tell you more about the Diabetes Compass. And yeah, the Diabetes Compass is a digital health solution or a group of solutions that aims to reduce vulnerabilities along what we call the diabetes care pathway, helping healthcare professionals and people living with diabetes. The diabetes care pathway is this thing that is on the screen right now. And this is where a person living with diabetes interacts with the healthcare system all the way from primary prevention to the right side of managing complications. And what we do know, even in the most advanced healthcare systems, is these vulnerabilities exist everywhere. The extent to which they exist differs from country to country. And we had this underlying assumption that we could use digital solutions to intervene and reduce reduce vulnerability in some of these areas of weakness. So we launched the Diabetes Compass in October last year in Tanzania, Sri Lanka, and Mexico. Unfortunately, Mexico fell out pretty quickly due to some political reasons. And have recently added Malawi to the mix. So we started with the idea that we could build a global reference solution based on 3 to 4 different countries, vastly different in terms of healthcare systems, population, and level of NCDs. The idea still remains that we can build some kind of global reference solution that can be scalable to some extent, or at least the underlying technologies can be scaled to other countries with local customization to the needs of each of those countries. As with all WDF projects, the Diabetes Compass is driven by a network of partners. In this case, the partners are quite numerous and diverse in their expertise. In Tanzania, we have most of our partners sitting in here today. From MUHAS, the Tanzania Diabetes Association, PROJ, and the Ministry of Health, and HISP Tanzania. And then at a global level, we have other partners that bring certain expertise, for example, artificial intelligence, diabetes care, strategic design, and research. And we have these partnerships in each country, which share experiences based on their current experience in the project. What we did find was that 4 opportunity spaces, or what we call opportunity spaces, started to emerge in each of the countries that we were working in. And these opportunity spaces is where we believe that we can use digital health interventions to create some kind of value for the patients and HCPs working in those countries. The first one and the most prominent one in each of the countries that we went to, and this is all 4 countries, was health information strengthening. Without access to proper data it is very difficult for anyone to do anything meaningful with digital health interventions. Moving to the right, early detection. This is also a massive challenge in some of the best healthcare systems to the least advanced healthcare systems. Too many people are finding themselves going into the care pathway at the later stage, showing signs of complications. And once you get to complications management, it becomes expensive, not just for the healthcare system, but also for society. So that was also a strong priority. The third one was HCP, or healthcare professional learning and performance support. In almost all facilities that we visited in these countries, the healthcare professionals said with better and more adequate training on NCD care, we could provide better care to our clients. Finally, and not the least important, but possibly the most complex, is self-management support. And that is providing tools to those that have the diseases to help them manage their own diseases. This is very challenging because everyone has a different experience with NCDs and they live a different life. Diabetes, for example, is different in every case. So you need some kind of tool that will help someone manage their specific case of diabetes, which involves customized solutions for each person. So that is one area we've decided not to focus on for the time being, and we've decided to focus on the first three of these interventions. What that manifests itself into in Tanzania in terms of technology is we have co-created with our partners in Tanzania the ideas around this. And we have decided that at the community level, we're going to build some kind of screening tool based on an existing solution in Tanzania, the Unified Community Health Platform, which will exchange data at the primary care sector with GodHomus, as Mark talked about earlier. In GodHomus, we're going to build together with PRR's ICT, or better, they're going to build an NCD microservice module, which is going to be implemented into the existing system with clinical decision support that will allow HCPs to make better decisions or more informed decisions in complex cases of diabetes and hypertension. Finally, that data will be exchanged to the national policy level without too much human intervention, as is the case today. It's a very manual process today. Our idea is that this will be automated, pushing data into a DHIS2 NCD data warehouse, which we're also going to build. I'm not going to spend too much time on this, but just to say that what was decided with all our partners is that we should not further fragment the already fragmented ecosystem. So you'll see that all of these systems here already exist in Tanzania, and we are just building on top of them. We're not adding anything new to the Tanzanian ecosystem. In terms of how we've done this, we followed a fairly typical design process, going from early discussions all the way to define, develop, deliver. I'll tell you a bit more about it. It sounds very boring when you look at it this way, and it's definitely not a very linear process. But in terms of where we are, both health information and early detection we've been working on for the last year. And just yesterday, we kicked off the health information development process. Early detection is hopefully soon to follow. And then the learning and performance support, we are still very much in the problem understanding phase, and we'll get to development probably early next year. Now onto something I believe Professor Sarah, who's not here anymore, would really like to hear, is how we've done this. And we've done this based on needs-based innovation. We decided very early on, and we were told very early on, not to come here with solutions, with our ideas of how to solve other people's problems, which we fully agree with. We don't know the Tanzanians' problems the same way they know their problems. The same goes for all countries. So we shouldn't come here with our idea of how to solve your problems. So I guess the easiest way to explain this is to show you this visualization of a traditional problem-solving method, which often involves people sitting in an office, defining a problem, coming up with various solutions from their perspective on how to solve that problem, trying to figure out which one they think fits best, choosing a solution. But what often happens here, because they haven't involved the user, is they come up with a solution that is not user-centric. And as we've heard numerous times today, user-centricism is super important. Otherwise, the user is not going to want to use the solution. This in contrast to what we've done with this needs-based innovation approach, takes a general problem, which we know based on the diabetes care pathway. We spend a lot of time researching this problem with our local partners, involving the users, and these users are everything from those that are actually going to use the system to those that are going to build the system, and really coming down to what are the actual problems that we can solve. We then sit together in numerous co-creation workshops, brainstorm what ideas could work and what ideas are sustainable and relevant, do some prototypes, and then iterate based on these prototypes, coming up with hopefully a very sustainable and long-term solution. In this process, we've realized, and these are by far not the only things that are important, but it is important to realize that we need to allocate sufficient time and resources upfront to really understanding the problem and the needs of the country. And this does take time, and with time comes money. So it is a very expensive process, but it is worth putting that up front. The other thing is the collaboration with local partners. It's something that a Teams call just doesn't work for. You really have to sit with local partners in their country and come up with solutions with them. The other thing that was really asked of us was to follow the principles of digital development. I know Felix likes to talk about these. And so we frequently go back to these and make sure that we're looking at these when we're developing solutions and putting a solution into a new country. To give you a better example of what this collaboration has looked like over the past year, it has involved many meetings, starting with the initial conversations, many design and co-creation workshops, which have taken a lot of time and effort to create. We then went and saw at the clinic level, at numerous clinics, if what we had done in these design workshops was actually reflected in the field. We met with various ministries, we co-created these concepts, and then we eventually came up with something that we call an experience vision, which is not a solution, but it's showing you what these ideas could look like if they were to become a solution, which we eventually got sign off in July 2022 for the first product areas, for the first 2 product areas. The other thing that was very important, both to local stakeholders and to us, was to align with strategic documents in country. So our solutions are very much aligned with Tanzania's primary healthcare digital transformation roadmap, and in many ways meet these criteria. Now on to possibly the most important part of this, what we've learned. I'm only taking 3 learnings, although I've learned a lot more than 3 things, even though I said to Bakari, I've learned nothing. I have actually learned something along this process. The team proximity has an accelerating effect on this. Again, it comes back to this whole idea that you can't really use Teams for everything. I think in many cases, people think that Teams has brought us closer together. In a setting like this, the only way to do this is to use focused workshops and bring everyone together in the same room. Technological development is a highly dynamic field to operate in. This requires flexibility, not only from us, but also from our partners. And sometimes this can be very frustrating. Sometimes we uncover a new technology halfway through the process of ideating that could completely change the system setup. And this is something that I've fought with myself. It gets very frustrating finding out, oh, there's something better now. But this is the only way technological development works. And the co-creation approach to solution development takes time and significant resources, not just in terms of money, but you're taking away people from their jobs, especially in the public sector and the healthcare sector. Sometimes we take 30 people out of their jobs for 2 days, and these are 30 people that should be serving the public or serving clients with diseases. So it is a very costly process. And that's why I would encourage this 100% to follow this process, but really understand why you're doing it and make sure that these workshops you have are getting the value that you want to get out of them. And with that said, asante sana. And for those that are interested, you can follow the journey where I will be posting numerous mistakes that we make along the way on some of these channels. Thank you very much.
Thank you.
Was I on time?
Yes.
Was I on time?
Yes, I hope so. I was not counting because the topic was very interesting. Can I ask Dr. Hadija and Martin to come forward, please, for question and answer? I think if you sit here, people will ask questions, otherwise they won't. So yes, we have topics on responsible and ethical use of digital health interventions, and then the journey that someone takes in developing a digital health solution. Can we have questions? Comments, questions, Karibuni? If you have a question or comment, please come forward so that you can ask the speakers. No one? Gloria, any comment on, yes? Come forward, please. I'm pointing Gloria because she has been working on data protection and ethical privacy issues, and she has a session tomorrow.
Good afternoon, everybody. Thank you, Madam. I was actually, I'm a lawyer by background. So that is why I'm always like, what is the human rights perspective of it? How do we protect the information? How do we protect the data that we collect? And you said it very well. It is really personal. And if it's going viral, it will really distract the person. So my simple question now, I'm thinking from the legal perspective. So I know you think from the scientific perspective. So I'm just thinking from the legal perspective. How do we ensure? And I think here there are so many innovators. How do we ensure that we come really with systems that are really able to protect the information, especially the personal information we get? I'm happy now we have a data protection law. I've been a champion of that as a personal, as I've seen, as you said, some of the information leaking. You have given the example, I think Elinor was telling me there is a leakage in US that is now creating chaos because of the data that has leaked. And it is really personal. You can leak a person, you can find it. And the innovators, can we come up with real solutions on the security of data and the information? That is what I'm, yes, from the legal perspective, I'll say ensure there is a law, criminalize, make sure exactly that whoever put the information off should be criminalized, should be taken into, but I'm thinking from the research lab perspective and from the scientific perspective, how do we do it really in practical sense?
I will ask Hadija, Dr. Hadija to come forward, and then Martin also on the same question.
Thank you very much for that challenging question. One thing you said that I'm looking at it as a researcher, but I have to tell you, no. I'm looking at it on the legal aspect because I had one job, which was to ensure that Tanzanians are protected from the services of a certain health profession. And for me, that was an eye-opener. It was a legal, ethical, and everything rolled into one. So I had that job for 3 years, and I made sure that the legal aspect is actually adhered and the ethical and the professional one. So it's a very cross-cutting issue. But now when we talk about digitalization into health research and into healthcare, I'm also chairing that ethical committee, which governs all the health research in the country. One of the challenges we have is, of course, leakage of information by data protection, but there's one thing we do. We really up and running on how the regulations are developed and adapted accordingly based on changes that happen across. So we do have, first we have an act, which gives us a mandate to do certain things and regulate. And then we do have guidelines, procedures, and you name it. We have all kind of regulations. And we go on adapting every day. And we also look into the specific groups And as we go along with the changes in research, I think when we started research in humans, we wanted to protect pregnant women after the thalidomide scandal. We wanted to protect pregnant women. But as time goes, it seems very obvious that you actually need to think about these vulnerable people, vulnerable groups, and include them in clinical trials, because once an effective medicine is available, they also have access. So it's changing. And I have to tell you, even though we're saying we have rules and regulations and acts, things are changing as we go on. Digital development is changing everything. We now have TikTok. Do you access TikTok? Yeah. In TikTok, we used to have Instagram. We started with Facebook, Instagram, and whatnot. Now we have TikTok. What is different with Instagram? In Instagram, you see all the perfect photographs. Every man who is there has 6 packs and you name it, strong biceps. Every lady has this very feminine figure. And that's an artifact. And then you have TikTok. TikTok, people actually disclose everything. They got burnt, they were born with a defect, they expose everything and say, this is me. Accept me as I am. This is reality. I'm sure, get a look. If there's any person in here does not look at TikTok, please download it and have a look. It's open your eyes. Yeah, because it gives you the reality. These are the bare facts. I'm a human. I didn't make myself. I was made. And this is how I am with all my faults and everything. So I'm thinking, not very scientifically though, but I think as we go on and evolve, there'll be no secrets. I think there will be a time when people would say, I have HIV. We do have that, but that's not, people would say, I have cancer, I have, double diseases, and this is me, and I need help. And I think that time is coming. So we will go on protecting as long as we're not violating human rights. We have to abide, we've ratified certain laws. But I think there will be a time when there are no secrets. And then when that time comes, no one will be lying, no one will be stealing, because everything is out in the open. That's my thinking. I hope I'm right. Time will tell.
Thank you very much, Dr. Adija Malima. Martin, 1 or 2 minutes.
Luckily, I can do this in under 2 minutes because I'm not a data expert. I think Mark said it from the beginning here, so the solutions that are built in Tanzania and especially in Godhomas bring on security experts from the very beginning for the reason of ensuring that data is protected right from the beginning. But one of the reasons that we are not getting into the fourth opportunity space of patient self-support is it relies on having so much patient data. And it's something that we are a bit afraid of getting into because of these issues around data security. And I think as much as I am a proponent of data security and all of these bureaucratic processes, I'm also someone to run away from the bureaucracy because as people trying to innovate in the healthcare sector, as soon as you add more layers of bureaucracy, it becomes very difficult to move things forward. And this is one of the challenges we face. But that being said, I do think in Tanzania, they have recently launched this Data Protection Act, which seems to be very progressive in terms of data protection acts. But none of, just to put everyone at ease, none of the data or none of the solutions we use take any data outside of Tanzania. Every piece of data is housed within the Ministry of Health and locally owned. We do not own any of the data that comes from these solutions.
A round of applause to Martin and Hadija for the nice presentation. May I request that you note down your question? We are going to have a panel discussion on NCD where Martin will be there. Tomorrow we are going to have a session on data protection and privacy. Gloria will be there. So if you have your questions, they will be responded accordingly. I now invite Sarah to take a lead. We are going to have 1 hour panel discussion. Please bear with us. We will, I think, before 5:15, we'll be there. Nice. Usawa is a program manager working on
Thank you very much. Good afternoon, everyone. You seem to be a little bit, I know it's after lunch, so people we are not with that. We can put them for a minute and stretch. Let's get it in the meantime. Let's take the class for, yeah, it's a second or two. Can I ask Martin? Can I ask for Valeria, Dr. Bakari, Dr. Felix, Dr. Manasseh, and Dr. Mashili to take the front seats, please. Well, we were supposed to have this session at least 14:50, and it's now 4:15. Dr. Felix, Dr. Manasseh, and Dr. Mashili. Quickly, let me quickly introduce the panelists, and I'll be very quickly because I will not go through the entire biographies for the interest of time. Dr. Felix, please. So we have Dr. Felix that you have seen and heard from him for a while. I have Dr. Manasseh. Dr. Manasseh, could you please introduce yourself quickly, please?
So my name is Dr. Manasseh Frank. I'm a palliative care public health specialist, practicing with my hands on the patients, but also doing a lot of public health work. Trained here at MUHAS 15 years ago, did my palliative care at University of Cape Town and Johns Hopkins University, US. And my interest is in community engagement in primary prevention of non-communicable disease. I work very close with the public sector, for instance, churches, social congregation, markets, in defining simple medicine and make it easy where diseases are actually generated, finding a solution. And I look forward to share my experience on this.
Thank you very much, Dr. Manasseh. So we've already heard from Martin. Can I call Valeria please quickly for a quick introduction? Good evening, everyone. My name is Valeria Milinga. I work with the Ministry of Health in the Non-Communicable Diseases Control Prevention Program. It's just at class. Thank you. Thank you very much. Dr. Bakari.
Thank you. Good evening. My name is Dr. Bakari Sam. I work with PRI as NCD coordinator. Thank you.
Thank you, everyone. So quickly, I will just go through. So the session basically is about the role of technology in addressing the NCDs in Tanzania. And I will quickly read the current burden of NCDs in Tanzania and also in East Africa. And this will be very short. So according to WHO disease burden and mortality estimates, the proportion of all the deaths in the WHO Africa region that are attributable to NCDs increased from 22.8%, that's 2.2 million,
in the year 2000 to 34.2. That's 3 million in the year 2016. In Kenya, 27% of all deaths are attributable to NCDs, followed by Burundi, whereas 32%. Rwanda has 33%, Uganda has 33%, and Tanzania has 44%. So the cardiovascular diseases cause 13% of all NCD-related deaths, followed by the malignant neoplasms, obviously with respiratory diseases, etc. But the most important NCD risk factors are high blood pressure, unhealthy diet, air pollution, high body mass index, tobacco use, alcohol, and drug abuse. In Tanzania, the NCD burden of disease has increased from 19% of the total disability adjusted life years in 1990 to 34% of the total DALYs in 2015. According to WHO estimates, a total of 409,000 deaths occurred in Tanzania in 2016 in a population of 55.6 million. And so this was contributed, this percentage, we had 33% of the NCD contributed deaths within the 56 million people in 2016. Of all the NCD deaths, 18% were premature, occurring in people aged 30 and 70 years. Hence this discussion this afternoon, how can we use technology to address NCD or to respond to the call of NCD deaths in our country? So to begin with, I have a few questions that I'm going to call upon the panelists to respond. And obviously, as I ask these questions, please take note if you have any other, because we don't have so much time, but make them very short. And I'll ask the panelists also to respond shortly because of time. So our first question goes to Dr. Bakari. How can one describe current readiness of the NCD management at the primary healthcare facilities in Tanzania? How can we describe the readiness of our facilities?
Thank you so much, moderator. Yeah, as I have been introduced, I'm from PRH, and our mandate at PRH is to coordinate or supervise implementation of various interventions at the council level and community level as well. So I'm standing here to share my experience as a health manager, not as a scientist. So saying that, I mean, most of the issues I'll be sharing is based on my experience as working at that level at PHC. So to begin with, I'm told to describe the readiness of the PHC to address the NCDs. This could be the difficult questions because I should have evidences to say whether it is ready or not. But maybe we can begin our discussion by looking into the reports from what we call Service Availability and Readiness Assessment from WHO, which is a framework for assessing how the facilities are ready or the facilities are available. So we had such a survey which was conducted in 2017 in our country, in more than 20 district councils. But also we have a midterm report for the previous health sector strategic plan. That is the 4th strategic plan for the country. We did a midterm report, midterm review, and both of the reports, the SARA report and the report and this midterm review, came up with the finding that less than half of the health facilities from at primary level provided NCD services, including diabetes, hypertension, and cancer. So again, it was also found that less than 30% of the healthcare providers at this level were trained on providing NCDs. But again, in terms of commodities, it was also shown that there's an erratic supplies of commodities for managing NCDs.
So I think we can fairly conclude based on these two reports that the services at PHC are optimally and suboptimally provided for NCDs. Again, from our supervisions, as PRI, you always do supervisions to visit facilities at lower levels. So we also see that most of these facilities, including at least hospitals, they don't have these NCD clinics. One of which you would expect that this at this level, at least at cancer level hospitals, they could be providing these NCD services. So let alone the health centers. So if you go to the health center, I think the situation, the situation is even worse, that we have some few health centers which provide NCD clinics, but you have most of the facilities, health centers does not provide NCD services. So as I said, we can fairly conclude that the status of our PHC service facilities provide NCD currently is suboptimal. So I think it will be also fair if I could also share the opportunities we have for using, if we could use primary healthcare level as an approach to address NCDs. And this has been even recommended by WHO. As we are struggling to address NCDs, it has been recommended that we use the approach, the PHC approach to address the NCD. This is because of the features of PHC. One of it, including the community involvement, the issues around integration nature of the PHC, but also we all know in most of the countries, PHC is the first entry of the health system. Most of the communities will enter the health system through PHC. So that's why it is recommended that we use the PHC to address NCD. So our country for the past 5 years have been a tremendous job to improve the health systems at primary healthcare level, including development of infrastructure. With infrastructures, I can, for example, mention construction of new health centers, rehabilitation of new, the old or dilapidated health centers. So in terms of infrastructure, we can see that a lot have been done to renovate and construct new health centers, which could in a way also provide an opportunity for us to include, to integrate with these NCD services, because before there was even lacking of space to provide NCDs. You go to a facility, we have only one consultation room. How can you now integrate or introduce these NCD services when you have a limited space for provision of these services? So with this infrastructure development, we see it as an opportunity, but also in terms of human resource for health. Nowadays, according to the guidelines, we are allowed to hire the medical officers up to the health center level. As we speak now, we have medical officers to most, if not all, of the health centers. So having the medical officers at that level gives us an opportunity to introduce introduce NCD services at that level. But also, my colleague maybe will speak on this, that we are also training these healthcare workers at that level to make sure that they also provide these NCD services. In terms of health commodities, we are now also, there have been a change in terms of guidelines for prescribers. There were some medicine which were initially not allowed to be prescribed at health centers, but now with the new arrangement, the new guidelines, now having the medical officers at cancer up to health center level, now they are allowed also to prescribe those medicine which were initially not allowed at that level. But also again, we have also pharmaceutical technicians at health centers. And in terms of health financing, we have now what we call DHFF, direct health financing. Now the funds are directly allocated to the health centers. Health centers are able to plan and utilize their funds. This give them opportunity to allocate some funds for procurement of medicine for NCDs, and bearing in mind that according to the planning guideline at the facility, the priorities, they have 13 priorities, and the fourth priority is NCD. So each of the health centers or health facilities are obliged to allocate some funds for addressing NCDs. So we have also an opportunity of using the community health workers to support facilities in terms of making sure that for those patients on NCD, making sure that they follow up in terms of the management, in terms of treatment, but also we are also thinking of using these community health workers in early detection of these NCDs. So maybe to conclude, I would just say that it is fair to discuss the opportunities, what we have in addressing these NCD at that level, as I have mentioned. But in terms of the readiness, I would also say the way we have now, I think we have the opportunities to address the NCD. Thank you.
Thank you very much, Dr. Bakari. I'm taking the keyword suboptimal as the status as it is so far, that we have less standards. And so now, can I call upon Ms. Valeria with the question being, what are the current country's strategies for fighting the NCDs that we are facing, and who are the key actors that you will recommend? Asante sana, Usara. So responding into what are the country's strategies into fighting the NCDs, and what are the key actors? So first, as a country, through the Ministry of Health, we have the guidelines. And these guidelines are specifically like being developed, overseen, and they're made through the non-communicable disease program in collaboration with other partners. So we have what we call the National Strategic Plan 3 for prevention and control of the non-communicable diseases. So through that document, it guides and sheds a light on what to be done across every level into addressing the non-communicable diseases. So another thing that we have is the multi-sector engagement, and this is mainly done by the Prime Minister's office. And for them at the moment, they are working on establishing the directorate, which would be responsible each overseeing other sectors on what they're doing to prevent and control of the non-communicable diseases. So before, the issue of NCDs was just overseen by the Ministry of Health and maybe very little from other sectors. But from this moment, as the Prime Minister office is working on this, we would have like scorecards, we would have different sectors being responsible to putting in place activities that reflects the prevention and control of the NCDs. And this would be, it is for them to be measured. Basically, they will have like scorecard and things of the like to see what they're doing into prevention and control. So another thing that we have is the coordination of the NCDs from the national down to the regional towards the councils. We have a program, the non-communicable disease prevention and control program, and as it operates, we have the PORAG, the President's office, whereby we have Dr. Bakari from the PORAG, and he oversees across the regions. So in all of our regions, across 26 regions, we have the NCD coordinators, and they also oversee other 184 non-communicable disease coordinators across all the councils. Now, apart from that, we have the parliamentary. Now, for them, they are well sensitized, and that made them to add role on non-communicable diseases into the committee, which is called the HIV, the committee that oversees HIV, tuberculosis, and drug use to have another role into overseeing the non-communicable disease prevention control. So what we do is whenever the parliament sits, we usually go and present what does the program do across, like from time to time, whenever the parliament sits. So this parliamentary, it gives some advice to the program. It tells them what to do, and it also sensitizes the other members of the parliament. And it's the one that advised that we need to have the multi-sector collaboration. And we made a way to the Prime Minister's office to ask for the multi-sector collaboration, which is already into development. Another strategy that we have is it includes the way we see how we could collaborate with other programs or with other services that are being provided. For example, at the moment, like this is happening in Zanzibar at the moment, we have people who are having a research on how to integrate the HIV services together with the non-communicable diseases. So with these findings, they would help us with how best we could collaborate and how to integrate these services. As Dr. Bakari mentioned, it's an issue of strengthening the primary health care. We are having a very important project whereby we are doing training across the health centers all over, like through 600 of them. And we expect to train about at least 4 healthcare providers who give services on the non-communicable diseases. And this is done in collaboration with Tanzania Diabetic Association through World Diabetes Foundation. And another thing we're doing is the issue of community sensitization, and this is mainly done through the non-communicable disease week. We call it NCD week. This is a very important activity that grants the program, also grants the NCD people. For example, we just finished the week this last Friday, and what we did, like it was held in Mwanza. So for this year, we reached about 300 people, at least just in Mwanza. But this activity is done all over the country. And since we started, we have reached about more than 12,000 people who are screened, and they're given like awareness and education concerning the non-communicable diseases. Well, we're also developing materials on non-communicable diseases, but we are also on the part of research. We are also working on we're putting everything in place to have the step survey, which would give us like will give us the situation on how the risk factors that influence the non-communicable diseases are. So we are soon going to have at least updated data on alcohol use, tobacco use, things with exercise, how do people physically active, and the issues on how, at what rate people are hypertensive or diabetes. And we also have the research agenda, as I mentioned. So to come into conclusion by answering who are the key stakeholders that we have people from different ministries, we have partners, we have media people, as now we have the Media Journalism Fellowship, that is to capacitate at least 10 journalists who will be capacitated on how to write the information on the non-communicable diseases. So with this one, we gave an announcement, and then we received about 83 applicants, and we just took 10 out of them. So you can imagine we have a number of media people that wants to be capacitated into issues with NCDs. So other group is the people living with NCDs themselves. They are also our very good partners, celebrities, religious leaders, as well as the traditional healers, without forgetting the people from the research institutions, as we are here with the people from MUHAS, but we're also talking about non-communicable disease. Thank you very much.
Thanks very much, Ms. Valeria. Thanks for sharing the current strategies of the country in addressing the NCDs. Now my third question goes to Martin. Martin, would you come to the front, please? As the question goes, what are some of the biggest health system challenges and opportunities to improve patients' outcomes for those living with NCDs in Tanzania?
Okay, we'll try to make this quick as well. So it's a slightly biased perspective working for the World Diabetes Foundation, but I've tried to put together a few of the biggest health system challenges that I see. There are obviously many, I cannot cover them all in 5 minutes. But I would say one of the biggest ones is funding availability and prioritization of funding towards NCDs. This is not just exclusive to Tanzania. We see this in many LMSCs, that funding priorities are towards the biggest burden at the time. So health systems are often reactive as opposed to proactive, because NCDs often take years to show, from screening, from the time of screening to or diagnosis to showing complications. And so there are many other disease priorities that need funding. And I guess these competing funding priorities are one of the big issues here. That being said, I think we see a big shift towards NCDs in Tanzania. We were at a conference the other day, a couple of months ago, with the Minister of Health, and she really emphasized the need to put more emphasis on NCDs and funding of NCDs. I think Dr. Bakari touched on the second point, and this is the lack of availability of early screening and quality data at both the community and facility level, showing the true burden of NCDs on the country. I think without that data, there is a kind of misconception that NCDs aren't as big a problem as they are today. And this early screening, which just so happens to be something we're working on the campus, could help with some of these challenges. Another one I want to touch upon is loss to follow-up. And this comes again back to lack of health information systems that are able to track patients along the continuum of care. Often if you go to one clinic in Tanzania and you get diagnosed with diabetes, if you move across the country, there is no health information on you at that point, and you could be diagnosed with something else. And this is also something Mark touched upon, continuum of care, and also the centralization of the government system. I think that is a huge step towards helping with this. The last one I want to touch upon is primary prevention and awareness. And I know this is something that there's a lot being done on, but I think many patients still today, or many citizens around the world, don't know the true cost of NCDs, both to their life and to society. And I think this is one of the key areas where strengthening is needed. But I'm sure we'll hear about this now. Yeah, those are my few points. Biggest health system burdens.
Yes. Thanks very much, Martin. Thanks for responding on that. So the fourth question goes to Dr. Felix. Is Dr. Felix there? Yes. So in the realization of the national NCD strategy, it is important to have relevant policies that describe and meet the settings that we are working at. How do we foresee the role of technology in service delivery coming into play?
Thank you very much, Director, Madam Chiza. We'll be taking from my colleagues on your question regarding how do we use digital health intervention to fight NCD. So I'll put it in a way that may be clear to most of us. We are used to build systems overnight. Mark can admit that sometimes we are called to develop a digital solution and be integrated tomorrow. Can you have a system within the next 2 days? I hope my colleagues have experienced someone ordering that we need supply chain system within a week. But you can't hear an order that we need a health facility to be built within a week. With a building, I compare it with building a software or a digital health solution. So you start by doing feasibility assessment or study, environmental impact assessment, you all the drawings, structural drawings, structures, and they all need to be approved by different experts. And you have engineers of all this. You have civil, you have structural, you have architectural, you have quantity surveyors, and the like. But unfortunately, as even as our discussion, Martin has pointed out that it needs to do with understanding the needs. What do we need to address for NCD? But it's also complex intervention that you need promotive component, preventive, curative, restorative, and now creative and domestic is going to talk. All these are business processes in terms of service development, but they are all linked also to other building blocks in terms of resource management, be finance, human resource, health and commodities. And we also need data for to govern leaders. So then we have a number of solutions that we have in place that we can capitalize on using and consider them as low-hanging fruit. And Dr. Lee was also talking about. So one is we have mobile penetration is high, even in the rural areas that Bakari was talking about. How can we use the presence of mobile network, mobile phones to really invest on health promotion, the preventive part, but also follow up implementation, as presented by Martin, that you need a system. So I would see that we can invest on this, and I'm happy that TDA, HBRI, and other partners are working on this in terms of creating platform for everything. There are some things which we can afford to use, but and where they developed using the 9 principles of mobility development, where they client centric. The client could be health user, healthcare provider, health manager, or the data services that we need. So that is what we look at, understanding the existing ecosystem. What system we have? We have NHS systems, management and like. How can we use data from NHS? Which are big data? So we can do big data analytics. NHS, DHS, plus EMIS. So these are all resources that we have at hand, where we have researchers, students, the like. Rather than the machine framing a system for each student, we can use the data to analyze even what is the situation, what are the data gaps, and other parameters that we do. So I can see using a mobile phones, the existing data, conducting research, which I think I was also emphasized in the morning when it gets to come. But we also need to look at then the architectural drawing of the government building. That needs all this to. We are talking of systems and are talking to each other. Systems are not exchanging data. But I think we need to integrate people first, integrate the business process before talking system integration. We need to have a business process by doing the mapping, analysis, and business process and engineering, so that we are developing a system as per the IT person required by the end user, depending on what business process is stipulated to provide information to get patient, because the LCD is long-term life condition, they are all interlinked. So we can use the existing solution, but we also need to work on the lessons that we have in terms of collaborative requirement development methodology, by making sure all the stakeholders are taken on board right from the beginning. This is importantly time-wise, but also because we need to have a lot of direction. And sometimes it irritates us. I know Martin, Makari, Valerie, and others have been into this trouble. Why don't we have system ready tomorrow? Why do we have done all the drawings in place? We are not used to that. So I'll take that diabetes focus as an example where we can invest in user-centric design, understanding existing systems, but being collaborative, data-driven, is privacy, but doing the research while we are implementing this game that we have. Thank you very much.
Thank you very much, Dr. Felix. I take the keyword data-driven approach, and that drives me to my fifth question that is directed to Dr. Mashili. Help us, Dr. Mashili, to contemplate on the saying that says, what gets measured gets managed, by telling us what is the data use culture in our country today, and maybe you can tell us more as in what are the key recommendations do you have for key stakeholders that have been mentioned here, talking of policymakers, implementing partners, healthcare professionals, and any other stakeholders for the future that we aim for when it comes to the response of the NCD in our country.
Thank you very much, Madam Moderator. There's a lot that we can discuss when it comes to data capture, especially during this era that we are seeing escalating levels of NCDs. I think to respond to that, and just to be very short, we really need to incorporate different systems to be able to capture the data. As Felix has said, we need to capture the data, but we also need to use this data. We need to analyze this data and to use this data for improving not just clinical practice, but also for prevention of NCDs. So one of the things that we really need to cooperate or to collaborate, I'm talking of the Ministry of Health, researchers, but other NGOs and anyone who is working with NCD, is to make sure that we have a system that can capture data in real time. So if somebody goes into the clinic, we have really good health information system that can capture the data, but we also need to have a system that can harvest this data, and then this data can somehow be centralized and be accessed by people who can analyze the data and making sense of that data. And then the analysis of that data automatically can also be, the system can also give the feedback from the analysis that have been done, and then the information can be sent back to the clinics or to the community for improvement of services. So integration of data capture to reflect daily clinical practice, but also to make sure that the data that is being captured is being used and is being analyzed to improve clinical practice, but also to make sure that the prevention of NCD is up to date. The other thing that I would like to talk about is the use of automated devices when it comes to diagnosis of NCDs. We know very well that most of the time we spend a lot of time, let's say, looking for radiologists to interpret the data. But now that we have artificial intelligence, algorithm can be fed into devices, and these are simple devices. And then you don't need to have radiologists to analyze the information. So you have the tools that can diagnose, or that can be used to diagnose patient. And then you have algorithms that have been integrated into those devices, and then you have automatic interpretation of those results. So instead of looking for radiologists to write a report or to read those ones, you just get the results automatically from these tools. So I think another thing that we really need to do is to incorporate these devices. We're already doing research whereby we are validating some of the simple tools that can be used to diagnose patient, where you don't need to have a skilled person to get the results interpreted. And these tools can also capture the data, and this data can be used for analysis. And again, as I've said, to know the prevalence, but also to improve clinical practice. At the end of the day, effective prevention and control of NCDs, because we know very well that we have a multitude of patients that are actually attending the clinics. And if you expect to get the results, and then the results have to be sent to one person who has to interpret and then bring back the results, I think it's going to take a lot of time. So if we utilize the tools, which we have, we are currently validating them to see how they're functioning in our population. And it's quite interesting seeing that we've got a lot of these tools that have artificial intelligence incorporated into those tools. And when they are used, you get the diagnosis, you get the interpretation of the results, and you don't have to have a queue of patients who are waiting for the radiologist or any skilled person to give the interpretation. So just to conclude, what I'm saying is the data capture, the use of artificial intelligence, automated devices that can actually capture the data, but also the data can be analyzed automatically, and then we can get results very fast, and also we can feed back to the clinics for the improvement of services. Thank you.
Thanks very much, Dr. Mashili. That was deep. I wish we had more time on data management issues. Now, my last question goes to Dr. Manasseh, who will tell us what digital solutions is he using in his community work that he's doing in the country And how does he address NCDs? Shares with you, that's the experience.
Now I understand why I speak last. I was wondering why. So in the past 20 years, I've spent my time actually initiating a foundation for the community because I'm really, really fond of the community in trying to find solution for NCD. So I will share my experience on what I've learned and how I've used the technology to address some of the issues that we encounter. So when we talk about community, I know we might be confused what sort of community I'm talking about. But whatever I'm going to talk will basically be driven by the gap that I perceive between the academic. When I talk about academic, I mean we practitioners, I mean the school students, and the community. And that is where there's a big problem and there's a big gap. I'm gonna stick on that area. So when I talk about the community, I mean the place where people spend most of their time relaxing, chill out. It's a place where all the diseases we talk about, they are produced. It's either through the way how we eat, how we sit, how we talk, how we drink. Most of the time, the community is a place where people reference. You tell them in the hospital, do 1, 2, 3, but there's a place where they go to ask whether they should do it or not. And sometimes they ask, should we continue with what we've been told? They go to ask, is this true? This is the community I'm talking about. And we perhaps never mention this when we talk about this in academics. And these are not other places as we speak about churches, marketplaces, mosques, schools, bus stops, trafficking, local government offices, people are filling their form. And these are the places where people reference their decisions. So I would consider this is where the community. Now, in my short explanation, I think there are 4 major, there are many, but I picked only 4 major gaps I think do exist. And we might need to think when we talk about digital in trying to address this. Number 1 is about language, very simple. I will give you a very simple example where one day I had to walk away when I started to talk about NCD. I was invited in one church and there were like around 100 priests. They challenged me by saying, you talk about, in Swahili, NCD means magonjwa sugu. So they were telling me, so if these are magonjwa sugu means you have failed. So in our philosophy, nothing is failed. So you bring them to us, we will take care of them. So, and this is what they tell their followers, that if you in the hospital fail to take care, we can take care. So does not end up there. It means they are telling them to stop. Like, for example, you have prescribed diabetic drugs for a patient, and you say this is a chronic disease, incurable disease. So they are going there and say, they've told you this is not cured. They've failed to treat it. So why are you taking medication? So this is their knowledge, and that's how they can explain. But behind this, there are so many other issues. Some people are doing business, some people are confusing. There are so many issues. So by doing that, it means these people will be having a lot of followers. But it's not that they're giving this service for free, they are paying. So you will see a lot of people going either to mosque, going to church for prayers. It's because of just information and the knowledge that you say you failed. And we are proud to say NCD, non-communicable disease, but I'm telling you, this is the barrier for millions of people outside there in the community where the diseases are produced. So we might think about talking about these issues when we discuss. Number 2 is about therapy. So there's a lot of myth at the community about the therapy. For example, we might have a very fancy, nice developed disease, treatment. For example, new treatment for diabetes, new treatment for hypertension. But very simple at the community, they say, immediately you start to use drug for diabetes, it's for your life. And so what's the problem with that? But that's a big problem at the community. Why should I use this for the entire life? Immediately when you start the drugs for hypertension, you lose your fertility or you lose nguvu za kiume, which is a very big issue at the community. You don't talk about that, you lose everybody. So when do we address that? So by doing so, we lose the interest of the community. They only listen to us, but they don't do whatever we say. And that's why there's a lot of default, refusal of therapy. You might prescribe a lot of drugs, but people don't take the drug. They don't take them because they reference somewhere that what you are taking will kill your ability to produce or your ability of your sexuality. So how do you intervene that information? Because 90% of the time they spend with those people whom they trust. They are emotional with them. So I think this is a big challenge, no matter what advance we have in the technology. If we don't really tap in that area, they have fun and but they never see any information counteracting what is actually out there. Number 3, I think accessibility. So we might have all these patients coming to us, attending clinic, we have a very fancy, nice clinic, but immediately when they leave from us and they go to the community, either they want reference information, they want help. I'm telling you, we are never accessible. Through telephone, we talk about digital phone. Try to call a doctor, you see how difficult you have. It's just a big, big challenge. But there are some other people who are accessible. You can call them, they can explain that they are good, they are able. So you can imagine this patient has been told that this is a chronic disease, incurable disease. You have to take drug. And then they go to this someone else who tells, oh, we can take care of this, we can cure this, there's nothing difficult. And they can give you reference. They have books. These books are very nice. They can say, we can kill, we can do everything. And then these people are accessible every time, day and night, and they can walk with them, they can deal with them when they cry, whatever. So they win the battle, and they use telephone to do this. Some people communicate in the night time just for prayers, taking care of people with the diabetic ketoacidosis. Throughout the night, they win the battle by using telephone. We never do this at all in the community. So number 4, as a challenge, I think it's about special groups. When we go to the community, as I said, we face a lot of challenge. We might think everybody is able to sit and listen, but you go there, people can't hear you, can't walk, can't hear. So, but these are the people with diabetes, with hypertension, with all the challenges we talk about. How do we communicate with them? How have we integrated these issues to get information to these people? So these are the challenges we face. Half of the people can't hear you. So I think technology can do that. Specifically in one group, for example, my interest in the past 2 years has been dealing with the seniors and older people. I'm telling you, it's a very big challenge because these are the people who have actually, with all kind of comorbidity, talk about the challenges of diabetes. It's about older people. So it's a big burden for the family, big burden for the community, big burden, and they are left out there. You want to see the challenges of diabetic food, go to the seniors, you see how hard and difficult challenges of access. So this is a big, big issue, talking about other disabilities. So I think technology has a role to help us on this. I picked only these 4, there are so many. So just working toward the end, I think the biggest challenge is, I think the assumption, I'll share with you a little bit of what practical I've been doing to actually move close to solving this. For example, I've been organizing small seminars with the small groups. You can identify based on the uniformity of that group. If you're talking about teachers, you're talking about priests, when you talk to them, sometimes it's very easy because you can interact, you can take their challenges and give them reference. I'll give you an example. One day I was speaking to the priests. They were like 20, around 100. So I cited a very simple example. I had a very small description to show how heart attack can happen. So when I was showing the video, it was like a 1-minute video. And this one priest who previously was really accusing us, doctors, saying that we are the cause of the death because we keep people with demons in the hospital for months and months. People with all the signs of demons, you keep them in the hospital, bring them to us. You see there, So when you understand, they'll say that at the beginning. But when I played the video showing how heart attack and correlate that with a sense of anxiety, how can they be connected with stress? And this priest woke up again and say, oh, that's why one of my choir members died. When they were fighting, one of the choir masters was saying, your voice is bad, and then I started to fight, and this like fall down and die. So we were able to connect that. So that's a very simple example, the power of doing simple community, not high science and technology, but then they start to believe and they can integrate that into their routine and preaching. So seminars are very, very good, but simple messages. For example, in my community, we have established a way of sharing messages, simple messages, very simple. For example, diabetes is incurable. If you don't take drugs properly, you might develop diabetic food and they'll be amputated. These messages are distributed. For example, every Sunday, we have messages distributed to all churches around my community. And when they do the announcement in the church, then they reach a point where they can say, this week message state 1, 2, 3, maybe eat fruits twice a week will help you from diabetes. So if it's read by the priest, it's very powerful than whoever said that. That's a very good example. We have also WhatsApp groups. Whoever passed in my clinic, I register them in a WhatsApp. So 3 times a week, we send messages, simple messages talking about clarification of the myth. Also they get time to ask questions on issues that they count in the community. So this is how you also get in the community, because they use that group as a reference. When they have something difficult, they discuss in the family, they can drop in the community. So you don't have to be there. You don't have to be there all the time with your business. So WhatsApp group is a very powerful way of getting to the community, because pretty much everybody has a WhatsApp group. Another thing is, of course, very few people have access to the web, but you can make simple messages for the community in language that they speak. That can be very, very helpful. But I remember also we started something we call Azimio la Kinyerezi Declaration, where we join hand with the priests, with the local government, with the market people, with the bus dala, and we agreed that if you cook without oil, you become special. So we started this to promote in our community. So people went to eat with these mama lishe so that they can be enhanced to eat the food that has been cooked with less salt or with no oil. It's a big challenge to get into that, but we were looking for the government, Dr. Bakari, if you have really tried to ask if you can come, at least to come and shake hands with those cooks, say that this is all the certificate. So these are the things we'd like, to promote the behavior at the community level. We do this, but we haven't done very well because people are very busy. But another thing, starting conferences. We started this year, conferences where we can bring all these people, like the church people, the government, and we science and talk about this issue. We did this year and next year in October, we'll be doing every year to speak a simple language with the people who are actually doing our work when we are busy with our science and academic. And I wish if we can join hands to do this. The last thing I will talk, whatever you do has a challenge. So I think one of the biggest challenge I want to say, one is assumption. Yeah, we think everybody is like us. We think everybody is smartphone, but they're also analog, where our assumption won't go to there. So how can we use those simple phones to get the messages into? But also cost. I tried during this year symposium conference where I did it here with around 200 people. But we tried to approach these digital people. For example, when TV, ITV, they wanted to charge us, and they were charging us a lot of money. And I was like, where do we get money? We're doing this voluntarily, we want to help people. And they wanted us to pay 10 memberships. We couldn't do it. And we did our program without anybody. So this is another big challenge. We are calling the digital, but they want us to pay it. So it's a challenge. You have to interact that so that we can get messages. So another and last issue, we have to think about people with disability, and we should not leave them away. It is possible. I'm sure digital can really help us to overcome the challenge of this.
Thank you so much, Dr. Manasseh. I can tell really we needed to put you last, but we could do with another session for community approaches. Thank you so much. And so, yes, thank you again, the panelists. Now, if we can take one or two questions from the floor, if any, or any comments before we get to the end. Or do we have any questions from the Zoom platform? Just check, there's a comment. Yes, I can read a comment from Frank Mohando. He's saying, hi everyone, I'm sorry that I was late to join the party. Very interesting topics. I am really interested in ethical conducts in digital health research and innovations. I was wondering if the presenters would be happy to share the presentations or any other materials. Thank you, Frank, that will be taken. Any other comments or any question? None? Okay. Any last comment from the panelists? None, and so I'd like to thank you once again. Thanks very much for your time. Thanks for listening. And I'll pass the mic to Wendy.
Thank you very much, the panelists. I think the round of applause that we gave was not enough. Can we stand up and clap for them? As much as we are talking about the students. Thank you. And now one talk more for Dr. Usara. Thank you very much for moderating this session. Panelists, please have your seat. Thank you very much for your active participation. It's 5:09 p.m. We have spent a lot of our time today discussing how we can digitally transform our health system. It has been a very important event. I wish you a nice evening and looking forward to seeing you tomorrow. Let's start at 8:30 so that we can conclude our session before 4. Is that the deal? Should we make a deal? We start at 8:30 and then we conclude before 4. Yes, thank you very much. Because we are starting weekend and we will have a celebration because we have concluded our week. I wish you enjoyable evening. Thank you. If there's anything, please contact me, Gloria, or the members of the organizing committee. Asanteni sana, Jamhuri ya Muungano wa Tanzania. Yes. Easy hapa.
Alisoma Dr. Sekela.
Hizi mnazikopi na kupesti kweli?
Si tukina